That's the other thing. The reason I bring it up, like, don't get caught, you know.
Good morning, everyone. We'll give it a few more minutes yet. I know we have a few members who are still joining, so we'll get started here in just a couple minutes. We're going to give it just another minute or two for a few more task force members to join here. So everyone, please hold tight. We'll get started in just a minute. Okay, everyone, good morning. Welcome to the 7th meeting of the Governor's Task Force on Reducing Prescription Drug Prices. It's 5 after 10 now. We're going to get started. I know we have a few more members who will be joining us. They can just join as we get rolling here. We have a very full agenda today, 6 presentations in total, so a lot to get through. So I just have a few quick housekeeping items to mention, and then we'll dive right into presentations after hearing a consumer story. First, as I mentioned yesterday, I will be wearing a mask again during today's meeting, again to continue to encourage and model good mask wearing behavior. Also, today's meeting will be recorded and live streamed by Wisconsin Eye. A reminder, as always, this is a public meeting, so we'll have members of the public who are joining to listen in on the discussion. As with previous meetings, please use the chat box to let me know if you'd like to speak and I can acknowledge you. As always, please keep your phones muted if you're not speaking. And also, I'm going to be a little more active today in terms of making sure we stay on time. As I mentioned, we have 6 presentations, a lot of content to get through. We still want to give everyone an opportunity to ask questions, but we do want to make sure we give all of our presenters a chance to give their presentations today. So that's all I have for intro housekeeping items. Are there any questions before we get started? Okay. Well, with that, we're going to try, hopefully 3rd time is a charm in terms of getting our audio to work on the video, but we're going to try playing a consumer experience story again today.
After that appointment, went home, went out, changed clothes, went outside, started working in my garden a little bit. Wife came out with a phone, and it was the doctor. The doctor said, we got your blood test results back, and we need you to pack a bag. You're going to the emergency room.
For a couple weeks, I had been showing the same symptoms my dad had. My mom had set up an appointment for me. So after school at about 3:30, I went to the doctor. They did some blood tests, and they said, pack up, you're going to the hospital, you have diabetes.
I still produce insulin. I still can get by with very little outside insulin. It's mostly changing my diet, exercise more, and in that way, where hers, she's 100% insulin dependent.
The learning curve is so great to change your life. When this happened, we got a diabetes magazine, and in it, there was an article about how to save money when you're a diabetic. What can you do? You don't go to the coffee shop every day. We never did. You don't go out to eat all the time. We never did. You don't take the super expensive vacation. You take the lesser expensive vacation. We'd never done that. There was nothing we could do to lessen the cost for us. You don't know what to do. You leave with, you need this to keep your child alive, and then you find out you can't afford it.
We have $5,000 out of pocket until we start the coinsurance. And then we pay 30% up to $10,000 maximum out of pocket. And we hit that. I've hit it every year for the last 5 years. I still pay my health insurance premiums, that are $7,000, $8,000 a year roughly for a family coverage plan. It's a big chunk of my check goes just to health insurance. And
we both have jobs. We don't do all the big things, and we're in our 50s, and we ask our parents for help. We ask our parents to help us pay medical bills, and they're generous, and they do, and we're lucky that we can ask them. Many people can't ask for help. They have nothing. They have no savings.
And I get the patent deal, and they have to do research and have to make money. But if you could cap medications, even older ones that are off patent or just about off patent.
That third party thing that with the pharmacy in the middle, that's insane. That drives price up so badly, and it's insane.
They're making a big chunk of money between the manufacturer and the end user, and that's got to be limited to something that is affordable to the end user.
We need the company, like I said before, accept all of the test strips, all of the test units. There's no reason not to, just because you've got a contract with a different company. And it's not just diabetes. I know you're working on diabetes, but it's anybody that needs a drug to live. You shouldn't have the right to hold that drug hostage to us or make it unaffordable to us.
The costs are borne upon these people, and if they can't afford it, they're exhausting everything they make or earn or have. So then they're on government assistance for housing, food, other things like that. So if you don't think this is affecting everybody, it really is.
It's important to realize that it's not just a couple hundred people. It is tens of millions of people who need this, who need to be helped, who need life-saving medication the price needs to drop, because they are putting prices on people's lives, and that is not acceptable.
After that.
Well, we really appreciate hearing Carly's story. And, as we've talked about before, and as the governor reinforced yesterday, we know that there are just many families who struggle with affording the medication that they need. And at the end of the day, that's why this task force was created by the governor, and that's what our work really needs to be focused on. So it's very, I think it's very grounding for us to continue to hear these stories, to really reinforce, why we're doing this work and really what we need to stay focused on as we continue to have these discussions and come up with some recommendations that can help in these types of situations and other similar situations that families are struggling with really across the state. So we really appreciate hearing that story. So now I'd like to turn it over to David with Optum, and give us a presentation about some of the real-time benefit tools that Optum Rx provides. So David, it's all yours.
Thanks, Nathan. Can you guys hear me okay?
Yes, we can.
Great. Well, good morning, everyone. And as introduced, I am David Calabrese, and I serve as Chief Pharmacy Officer here at Optum Rx. For those of you unfamiliar with Optum Rx, we are a National Pharmacy Care Services, or PBM, organization. We represent about 65 million lives across the United States today, both public and private sector. And in my role, I have executive level oversight, accountability for a number of our clinical programs and services, some of which I'll talk about today, and help to set forth our overarching clinical strategy for the organization and ensuring we execute on that strategy. Want to start off by, first of all, thanking all of you for allowing me this opportunity today to be here and to participate in your meeting. And I applaud all of you. I applaud Governor Evers. I applaud you, Nathan, for leading this group, and all of you for lending your time and your expertise, diverse experience to this critically important effort that's affecting so many families, so many individuals, such as those that were featured in that video. And want to let you know that we do stand beside you, behind you, and welcome the opportunity to collaborate as part of your task force efforts, with Robin representing us, on this task force to help drive the successes that you're attempting to achieve. If we can go to the first slide, Megan. One more, please. So as an organization, I can tell you firsthand, being a member of our executive leadership team, that foremost, as an organization, in an effort to achieve our mission, our vision, which is optimizing quality of care, optimizing cost efficiency of care. In order to do that, we understand very clearly that to drive and to champion optimal health and wellness for those that we serve, we must do everything we possibly can to ensure that, first and foremost, that patients have appropriate access to the medications they need at an out-of-pocket expense that's affordable to them for the management of not only chronic disease, but acute disease as well. And this becomes that much more paramount, as we're all readily aware in today's environment with COVID and the economic implications that come along with that. So we've put together a wide array of strategies to do just that. We've created a very large toolbox of tools and resources that are helping to guide both the provider who's writing these prescriptions, the consumer, the patient who's receiving these prescriptions, and our clients, the plan sponsors, in terms of how they structure their benefits, how they structure formulary and utilization management programs in ways that could better advocate for that member, ensure that they're able to access these medications at the lowest possible cost. Today, we're going to focus on, if we can go to the next slide, today we're going to focus on what's commonly referred to in the industry as real-time benefit tools. These are tools that are designed to engage, in this case, the provider, the patient, and internally our own resources that are touch points for the members with regard to where and when there are opportunities for that patient to save money by switching to an alternative drug that may be utilized for the same indication, that is as safe, as effective, but maybe available, in a generic form, or maybe available in a less costly branded form based on their benefit and where they are in that benefit. And these two tools are called MyScriptFinder, which is member focused, consumer focused, and PreCheck MyScript, which is more of a provider focused type of tool. Today, we believe that these are critically important in terms of promoting the type of transparency that we're hoping to drive in the industry, providing timely, meaningful, actionable insights to both the prescriber and the consumer, allowing them to be more empowered, allowing them greater visibility into the cost of medications, and to be able to, in today's technologically advanced, digitally focused type of environment, to meet their needs in ways they need those needs met. So part of the doctor's day-to-day workflow, part of the patient's day-to-day ways in which they want to be communicated with. And as we all know, digital is a big part of that today. So if we can go to the next slide, please. So before I dive into the tools themselves, I think it's also important to share with you how we manage, what drives the information that we're providing within these tools. And behind the scenes is one of the largest repositories of data and information in the healthcare industry today. It's a tool that we call Optum IQ. And within Optum IQ, we're pulling disparate data and information from numerous sources, integrating that and translating that data into useful information that then can be provided to help us achieve our goals. And one of those key goals, as I said, is price transparency, is cost information. And within our organization, the team that's responsible for building that information is our drug intelligence team. They reside under me within the organization. These are a large array of clinical experts, primarily pharmacists. We also have nurses. We also have certified diabetes educators. We have access to multiple physicians across multiple specialties. And one of the jobs of that team is identifying routinely, based on the therapeutic areas they're most expert in, identifying routinely for existing drugs on the market today, for new drugs that are making their way to the market tomorrow, what are, if any, what are the alternatives that are available, and how do they compare price-wise, to existing standards. And by doing that, we're able to feed consistently this database such that we always have the most robust set of information possible to be able to share back with the various constituents with which we interact on a regular basis. And what you see before you is the consumer-focused tool that I referenced called MyScriptFinder. So, as all of us do, we have multiple apps on our cell phones, and we've created this particular tool to allow us to better communicate in ways that our consumers want to be communicated with digitally. And we've put an enormous amount of time, effort, resource, dollars into developing this tool. We've done focus groups with patients. We've done work with consultant organizations. We've done work with vendors that have extensive experience in this area to create a tool that's very member-friendly, easy to utilize, and offers them the opportunity to search those medications they may be on today, those medications their doctor may be prescribing to them tomorrow, and to better understand whether there are options available to them that are less costly for their condition. Additionally, it provides them information on lower cost channels. Oftentimes drug benefits are structured in a way that if you fill your prescriptions at one pharmacy versus another, you may have lower out-of-pocket expenditures. Well, this tool also can help drive channel management as well so that the patient can save money. What's most unique about the tool is that the data is very patient-centric. And what I mean by that is, if I'm utilizing the tool today because I'm on, cholesterol drug X, and I want to see if there's a less expensive cholesterol drug available to me, the information that's going to be displayed is based on my benefit provided by my plan sponsor on that day, based on the pricing that's available to us across the various channels, whether they be retail, home delivery, specialty, whatever. But most importantly, it's based on my benefit. So if I'm in my deductible phase of my benefit, it's going to tell me exactly as I get to the pharmacy what my out-of-pocket is going to be based on where I am in my deductible. If I have co-insurance, it's going to tell me exactly what my co-insurance responsibilities will be for drug A versus B. So very member-friendly, very focused on providing the most accurate and transparent information possible for that member and guiding them in a better way. Now, as I get into the tools, note that, we're not unique. Most PBMs offer these types of real-time benefit tools. They may vary from one to another in terms of the platform in which they operate, in terms of the bells and whistles that are incorporated, the manner in which information is displayed, et cetera. But this has become a standard within our industry today. And we learn as we go, and we build on these and we refine them based on feedback from organizations, from clients, from members themselves who are utilizing them. So that's the patient tool. What I'd like to go to next is, if we can go to the next slide, Megan. So the other tool that I want to talk about is something called Pre-Check My Script. And this one for me is the more exciting of the tool. I've been in managed care pharmacy practice for over 30 years now. And one of the things that's eluded us in our ability to better manage pharmacy at a population-based level, it's kind of been the holy grail for us. And we've never been able to actually, grab at it up until now, is the ability to influence prescribing behavior before it happens or when it's happening. So a lot of the tools that we've employed to date are what I would consider retrospective in nature, right? So doctor writes script, patient gets script, we get the data and we see, oh, that patient could have had a less costly alternative. Now we've got to go through this arduous process of intervening with the patient, intervening with the doc to see if we can get them converted to a lesser costly generic. With real-time benefit tools like Pre-Check My Script, we have the ability now to actually interface with the physician's EMR. And when I am sitting in front of my doctor within that exam room, and every doctor has it seems has a laptop in front of them and in a screen where they're looking at my claims history or my prescription drug history or whatever it might be. Now we have the ability to interact with that doctor in real time. So if I'm newly diagnosed with diabetes and that doc is about to prescribe a medication for me for my diabetes, they will now be able to, through real-time alerts that we provide, they will be able to see how much that medication will cost me when I get to the pharmacy. They will be able to see, are there lesser costly options available to me? What are those options and what exactly will those cost me out of pocket when I get to the pharmacy? They will be able to see which pharmacy may be able to provide that to me at the lowest cost based on my benefit. They will be able to provide, if that particular drug is subject to some type of utilization management protocol, such as prior authorization or step therapy, they will know that at the point of prescribing. And they will be able to advise me whether there are other medications that may not require prior authorization, may not require step edit, so that when I get to the pharmacy, I'm not going to run into a situation where that pharmacist says, I can't fill your script, it requires PA, or I can't fill that script because you haven't tried drug X first before going on this medication. So that's very powerful information that helps to facilitate and limit facilitate the process of prescribing, improve that prescriber-patient relationship, minimize disruption, administrative burden, and it's extremely effective and well received by the provider community to date. And I'll get into some of the numbers. Is there a question? Okay. So in addition, this is something that we continue to build upon. And one of the things that, again, I'm most excited about is we can also, at the point of prescribing with this tool, educate the doctor relative to actionable clinical alerts. So we all know that we're in the midst of a major opioid epidemic right now that is further exacerbated by COVID. What this tool allows us to do is when that doctor, if that doctor were to write an opioid prescription, we can make sure that that prescription is being issued in accordance with CDC guidelines relative to dose and duration of therapy. We can educate the doc if there's a conflict. Maybe that patient is receiving a benzodiazepine from another provider that doc's not aware of. Those are the type of alerts that we can also, just like you get them at the pharmacy, now we can provide some of those in a very judicious manner to the provider when they're writing those prescriptions and help to avoid negative clinical circumstances. But today's focus is affordability, and that's where I want to spend most of the time, for the rest of the presentation. So if we can go to the next slide. So on this slide, you can see the benefits that are afforded to all constituents, all stakeholders in the process of pharmacy care management as a result of this ability to better interface, to better communicate, to better coordinate data and information. The member benefits, you can see the average cost per script savings that are available to the member. When you improve savings to the member out of pocket, that will drive higher adherence. It's well documented in the literature. Lower out of pocket means typically translates to greater medication adherence, which in turn hopefully will drive lower total cost of care, better quality of care for that member. And you can see, whenever there is a high cost, high out of pocket, say tier 3 non-preferred medication, we're able to convert the majority of those to a lesser cost option for those patients. For the client, the plan sponsor, again, whether they be public or private, we're able to drive savings for them as well by switching, encouraging switch to lower cost option. For the pharmacist, lesser administrative time dealing with, claims that are rejecting. So there is administrative cost savings through this product, and the same applies to the physician. By avoiding a PA or by having the ability to process a prior auth right then and there, there's an administrative savings to them as well. And by the end of 2020, we are headed to an 80% access target for all physicians across the United States. You can see the 2020 performance. We've now have over 400,000 docs utilizing the tool. We're impacting more than 1.5 million members per month. The response time, so it's not creating an administrative burden in terms of response time. It's a very quick tool and provides value in terms of promoting those lower cost alternatives and avoiding unnecessary prior auths that can drive lesser costly options for that patient. Next slide, please. So lastly, this is, as I said, a fairly new tool. Our goals with this moving forward are obviously to enhance access to the tool. So integrating with more EMRs so that we can get an even broader access by physicians to the tool. At the adoption level, utilization level, we want to add in information like medical diagnosis codes that will further drive smart edits, smart communications back to the provider, that can enhance, that much further the quality of care that's being delivered. We also want to be able to fully display, pharmacy channel options for that patient, and then expand upon some of that clinical messaging that I talked about, that we're doing in areas like our opiate risk management program. Again, all with the goals of achieving that triple aim of, greater affordability, greater quality, and better service, both to the provider and to the member. So I'll stop there. I'm glad to field any questions. I think I've left enough time for a few questions, but hopefully that provides you, a decent understanding of where we're investing in terms of resources at point of care in real time to try and influence and help you in your efforts in driving drug affordability. So again, thank you for your time.
Great. Well, thank you, David. Really appreciate that presentation and that overview. A lot of good information there. And it kind of wraps up some of the discussions we've been having around some of this understanding about real-time benefit understanding for patients and doctors. So thank you. That's very helpful. Are there any questions? Looks like Dr. Goldrosen has a question. Go ahead.
So of course, this goes along with some stuff I've asked in the past, and I'm glad to see Optum Rx has the tool available to patients and integrating with EMRs. The EMR that I am on does show me information on formulary status. I don't know for sure if it does for Optum Rx or not, but for some times it'll show me that. For some insurance companies, it'll show me alternate choices if something is not on formulary. Ours does not yet have it turned on where I can see the cost information, but I know it sounds like you have it so that it would show what the out-of-pocket cost would be for the patient.
Right.
I were able to see that. Does it also show what the total cost is then, so that I could compare, something might be $10 out of pocket for the copay, but one drug might cost $200 and one drug might cost $600. Does it give that kind of information too? So both us as well as the patient on their end on the app could see, hey, there's something that might be less costly to the whole system and thus to them ultimately, even if the copay is different.
Yeah, today it's primarily designed to drive patient out-of-pocket affordability, but if that's something you feel additionally would be of value, we have had that request before. Can we display both, the ingredient cost of the different medications and how they compare to one another? I know that's being explored as well. We're trying to, one of the difficult balancing acts with this is we don't want to overload the physician with information. So even with clinical alerts, what we find at the pharmacy is you can have information overload, and what ends up happening is docs and pharmacists just bypass these alerts because they're just getting buried with them. So it's a difficult balancing act in terms of how much information we provide. But if you believe that there would be an opportunity there, I know that we have talked about that internally. Do we provide both? As it's structured today, it's primarily a patient affordability effort, but that may be an opportunity as well for us to build in moving forward. And I appreciate that feedback.
Yeah, I would think something that doesn't necessarily pop up every time, but something that at least we could look if we wanted to. So, I don't need it to pop up the drug costs and the patient's out-of-pocket costs every time I write a prescription for metoprolol or something, but
sure.
Or at least potentially higher cost medications, or if we're not sure about it, well, to see the out-of-pocket costs as well as to see some cost comparisons, could help myself as a physician make a better choice.
I appreciate that. And, there are some other things that we're working on to create that greater visibility for providers in certain therapeutic areas, particularly where we've seen the introduction of these egregiously priced products. Some exploitation of the pricing realm from different smaller niche companies where there are extremely lower price options available. So we're building some of that and disseminating some of that. But there are other ways we can do that as well.
Thank you.
Great. Well, thank you for those questions, Doctor. And David, thanks again for your presentation. Looks like Brian Sam, you have a question? Go ahead.
Yeah, just a real quick question. David, thank you so much for presenting this information. It looks really good, and I really hope this works for your membership. My question is, for those that aren't part of your membership, do you have any policy-based recommendations that could I guess, hit the broad spectrum for addressing drug pricing?
Broad scale policy recommendations for address, it's drug cost, drug pricing is a, very complex, area in general. So I don't think that we have one single policy that addresses drug pricing in general. What we have is a compilation of different tools, resources, and policies designed to, when brought together, can achieve those objectives. So, as I said at the outset, we're more than willing to take this to another level with you guys, whether it's a subgroup or whatever, to kind of walk you through all of those different tools, resources, policies that we have that are, specifically designed, and I'm helping to lead some of these efforts, specifically designed to drive financial advocacy for the member, drive affordability and access for the member. So no, we don't have one unique policy, but we do have a compilation of a variety of them, a variety of tools and resources that are driving that. Appreciate the question, Brian.
Thanks, Brian. Tony, you have a question? Go ahead.
Yeah, thank you. David, how does this take into account the different tools for lowering the prices for the patients, like the manufacturer's assistance programs and the different things like that? And then just kind of as a follow-up to how the system works, you had mentioned that it tells you the most cost-effective pharmacy. How often then does that point back to potentially the mail order option?
Yeah, so I'll take the first one. As far as copay assistance programs, these tools don't take that into consideration. Oftentimes, as you're well aware, those copay assistance programs are designed to bypass many of the tools, resources that we bring forth to control prescription drug expenditures, right? So if it's a high cost branded medication that, we have, prior authorization, step therapy, high copay on for a reason, it's because there are lesser cost options available, typically generic options available. The copay assistance programs are designed so that they can keep members on those drugs, but in the long run, it's costing the plan sponsor that much more. So there are tools that we employ, like variable copay solutions and so forth, that help to balance that at the plan sponsor level. But, our efforts are, looking at the true net cost of medications and driving patients and providers to those lower net cost options. As far as your second question around delivery channel, again, that's going to be specific to that patient's benefit. So, we're not going to drive patients to just our home delivery option if that isn't the most cost-effective option for the patient. Oftentimes we have 90-day retail benefits where the out-of-pocket is the same as our home delivery. So we will display those options equally and allow the patient and the provider to have that conversation and determine what's the most appropriate, most convenient option for that member. But it is driven by their particular benefit design.
Thank you.
Yep, thanks for the question, Tony.
Sounds good. Looks like we don't have any more questions, but thank you again, David. Really appreciate the presentation. Appreciate you taking the time to be here today.
My pleasure, and look forward to coming back if needed and continuing our conversation moving forward. Thanks to everyone for your time and attention.
That's good. Thank you. Okay, moving on to the next presentation, we're going to hear from Renee Walk from ETF. She's going to talk about the Wisconsin Pharmacy Cost Study Committee and the final report from this committee. This was the multi-agency kind of bulk purchasing initiative that ETF has been heading up over the past year. I've been a part of this initiative, as has Brian Stamm. We've had very good discussions. I want to say Renee and her team have been fantastic in terms of supporting this work and putting together the final report. So look forward to hearing her presentation. So Renee, I'll turn it over to you.
All right, thank you so much. Hopefully you can hear me okay. And
Yes,
I
we
will
can.
just dive right in because great. I'll just dive right in because it looks like you have quite an agenda today. So let me see if I can advance slides. There we go. Oops, too far. So good morning again. My name is Renee Walk. I'm the lead policy advisor for the Department of Employee Trust Fund's Office of Strategic Health Policy. And as Nathan mentioned, that I'll be reviewing our final work from the Wisconsin Pharmacy Cost Study Committee. So to start with just a bit of background, the Pharmacy Cost Study Committee, or WPCSC, started in 2017 as a series of informal collaborative meetings between employee trust funds, who provides health insurance and pharmacy benefits to state and local employees, and the Department of Health Services Division of Medicaid Services. And we soon narrowed our focus down to drug purchasing, given both the size of the expenditures in each of our programs and the rate of growth in that area. And then in about 2018, we also broadened our scope to add other large agency state purchasers. And so at that time, we added Department of Corrections, as well as the Division of Care and Treatment Services that's also within DHS, Department of Health Services. In 2019, we applied as for technical assistance from the National Governors Association. And at that time, we also expanded our membership to include both the Office of the Commissioner of Insurance, as well as the Governor's Office. And so that formed the committee in its most current state. The committee has also been supported by a staff working group, and that working group has been meeting also to analyze available data, as well as policy options, and working with NGA to present options to our committee. Our work is focused on two tracks. We have focused on options to improve individual purchasing approaches for individual agencies, as well as a pooled purchasing option or set of options to leverage our combined agency buying power to try to lower costs. And so the committee has reviewed options, and we've made provided a few recommendations as appropriate. So I will start with individual agency options that the committee has reviewed for recommendation. There we go. So many of our individual agency options focused on whether there would be ways to leverage the 340B program to bring down program costs. So the first option I'll talk about related to that is what we describe as a Centers of Excellence model. And this model would entail individual agencies contracting directly with 340B hospitals or other 340B entities. And these contracts could require that the hospital pass through the cost of the 340B drug at acquisition cost instead of marking up the drug to a commercial rate in exchange for the increased patients and then the increased associated revenue that those patients would bring. From ETF's perspective, we have some concerns that this type of contract could be first in conflict with our fully transparent pharmacy benefit model that we currently operate under. So our contracts at this time require our pharmacy benefit manager to, in part, provide full visibility into our manufacturer and provider contracts, and that includes price transparency. Under federal law, though, the 340B pricing, of course, is confidential and can't be disclosed. So ETF feels that transparency is really critical to our ability to fairly steward member and taxpayer dollars, and this was a provision that we weren't quite comfortable with. In addition, we currently contract with fully insured health insurance programs, or providers rather, for our medical services, and this arrangement would require carving out potentially a substantial amount of our medical services to a separate or secondary contract. And so we had concerns about not only changing that model, but also about our ability to do so in a way that wouldn't compromise member quality of care or our ability to create contracts that would equitably serve our membership. Similarly, Medicaid had concerns about their ability regarding the limiting member choice. So under federal law, Medicaid must provide freedom of choice to all of their members in the program unless the program itself files for a freedom of choice waiver. Medicaid had concerns too about their ability to equitably implement a waiver like this between rural and urban communities. Interestingly, the Department of Corrections actually has the ability to pull down 340B pricing to their current contracts with UW Health. But in order for the patient to be eligible for 340B pricing, that patient has to be a patient of record with the 340B entity. This presents a host of logistical concerns, including moving DOC clients from their in-house medical care to the UW for care, which in many cases would result in a substantial cost related to physical transport because DOC's largest footprint is outside of Dane County, where UW has their largest care footprint. UW would also have to create and hold a portion of their hospital beds separate due to DOC security requirements, and that means that those beds would not be usable by non-DOC clients. And because of these factors, they felt that both DOC and UW felt that they had the cost to actually move forward with this provision would be prohibitive. The next 340B option that we reviewed talked about a billing requirement where agencies could require 340B entities simply to bill only for acquisition costs as a part of their contractual relationship. The same concepts apply here and the same challenges that apply here from the 340B Center of Excellence model, including the price confidentiality, which really limits agency ability to audit whether or not 340B prices are actually being passed through. From ETF's perspective, again, similar to the Centers of Excellence challenges, we don't contract directly with providers at this time, and so we don't have direct influence over their contract arrangements. And Medicaid is already supposed to be receiving 340B pricing from eligible providers, though, again, there are challenges to auditing this. DOC's challenges with this option were similar to the Centers of Excellence model, where it would involve them actually moving patients to the proximate site of care. So we opted, or this option did not seem like a promising one for us. The most promising 340B option that the committee reviewed was related to, was specifically for DOC and related to creating a relationship with public health. So public health entities that receive grant funding under Section 317 and 318 of the Public Health Service Act can become 340B eligible and receive 340B pricing. And they can also enter into sub-grantee relationships with organizations for whom they've established a service relationship. This includes correctional institutions, and several other states' DOCs have already created these kinds of relationships for their clients. The Wisconsin Department of Public Health was favorable to us creating this kind of relationship, and DOC's current pharmacy purchasing contract through the Minnesota Multi-State Contracting Alliance for Pharmacy, or MCAP, can facilitate the pass-through of 340B pricing without jeopardizing other DOC pricing arrangements. So DOC would not need to disrupt their current purchasing arrangements. All right, the last individual agency option that we reviewed is related to value-based contracting. And so value-based contracts can either be volume-based, so like the subscription models that states like Louisiana have entered into, where the entity pays a fixed price amount for unlimited access to a drug, or they can be outcomes-based, such as those held by states like Oklahoma, where those arrangements tie reimbursement for the drug to the health outcomes of a patient. The idea being that the better the health outcomes, the better the pricing that the drug company receives. While our committee agreed that the contracts were interesting, there are substantial administrative hurdles to setting up these kinds of contracts. Other states that we talked to noted that contracts often took many years to establish, that meaningful outcomes were hard to define, that access to health data in particular to prove outcomes was very limited by privacy law, and that to date outcomes for those existing contracts that other states have entered into have yet to bear out. And so we don't know what those outcomes are yet in terms of whether states were able to save money. States that set up these arrangements also noted that they often required additional staff and substantial additional data and analytics capacity to administer, and that they had found few drug companies at the end of the day that were ultimately interested in striking these agreements. So next, I'll review the combined agency options. And so these were options that we talked about for combining our total purchasing power to leverage better prices. And the first option that we talked about was true pooled purchasing. So this would be an opportunity for our agencies to work together either directly or through a common vendor to negotiate better prices for our entire block of business. This could entail co-negotiating rebates or supplemental rebates in the case of Medicaid. DOC, I should note, does not currently receive drug rebates. They receive simply a pass-through reduction or a pass-through discount in prices through MCAP. Medicaid right now works with the Top Dollar program to receive supplemental rebates in addition to their federal rebates that all states receive. And the theory here was that the combined volume could entice manufacturers perhaps to strike better deals for all of our agencies across the board. However, the lack of transparent data, again, from all agencies on current pricing makes any combined purchasing project very high risk. We can't tell who is getting what deals currently, and so it's very hard to tell which direction or how to better negotiate prices in good faith. The purchasing data that was available also indicated, from what we could tell, that the savings reward could be quite limited, and the agencies agreed that it would be very challenging to disrupt our current purchasing systems and our members, particularly that there was no clear future owner of this type of combined purchasing agreements as well. The other option that we discussed related to combined purchasing is more of a quasi-combined purchasing arrangement. And this would be alignment of our preferred drug lists on the Medicaid side with ETF and DOC's closed formularies. This would be less administratively challenging. Medicaid, of course, cannot have a closed formulary without foregoing their federal rebates due to the choice issues. But this would create a potentially, again, quasi-pooled purchasing approach where the agencies would move their buying power closer together towards the same products in the hopes that we would be able to leverage that volume more indirectly. However, there is no guarantee of price impacts in these types of arrangements, and conversely, there would be potentially substantial member disruption across programs. So at the close of the committee's work together, the only option that we did recommend our co-agency move forward with was the DOC 340B pricing arrangement. So this project is currently in progress, delayed slightly due to the pandemic, but their target is still that DOC clients be eligible for and receiving 340B pricing by 2021. The other concepts were either not administratively feasible, the savings were insignificant or unknowable, or the disruption for the agency's review was just too great and would outweigh the potential savings. In addition to these options, though, we identified several other options that we deemed out of scope for our work, but that we would like to review with the task force for your consideration. So these out-of-scope options were often discovered as our committee was working through the options that we presented. And some of these would have either facilitated our ability to actually pursue the options presented. Others were really raised as moonshot ideas that we felt could really actually disrupt the current state of how drugs are purchased in the state. So first, the first issue that we raised was price transparency. And I talked about this a bit throughout my presentation, but more specifically, this has been a popular item of consideration for many other states. And we at ETF find price transparency to be one of the key pillars of our overall pharmacy program. The WPCSC's work was also substantially hampered by our inability to truly analyze costs across programs, and that particularly pertains to the Medicaid program. We were perplexed by the idea that even between agencies, we couldn't share how we were allocating taxpayer dollars within our programs, and that idea was a critical hindrance to our ability to negotiate anything in good faith for better pricing. However, we noted or would like to note that state level laws may not be sufficient to achieve the kind of transparency needed for these types of projects. So again, 340B, Medicaid best price, and the federal supply schedule that the Department of Veterans Affairs purchases from are all protected by federal confidentiality rules and may not be accessible even if the state law is passed. Second, we discussed the option briefly of drug reimportation. And so ETF colleagues in Utah have recently begun a pharmacy tourism program for their state workers. And the information they've shared with us showed that even after airfare, guide services, and a visit with a local doctor in both Canada and Mexico, depending upon which country currently has best pricing, patients were still receiving better prices on specialty drugs than under their old PBM. However, there are several reasons to believe that the utility of these programs may be limited. First, it's likely that drug companies and countries themselves would begin to push back more and more if US citizens begin traveling there to purchase cheaper drugs on the regular. Plus, of course, the current public health crisis limits the ability of people to take advantage of such programs. The other two concepts that we reviewed include a sole statewide purchasing entity. So consistently throughout our process, the WPCSC noted that many of our transparency problems, absent transparency laws, could be mitigated if we were all operating under the same roof. And so if we had the right to review all relevant information, or if at least one of us had the right to review all relevant information. Organizing this is beyond our scope as our committee, but a single statewide drug purchasing entity could facilitate that kind of review. This would, though, be a substantial reorganization of how our agencies purchase drugs and would likely require legislation. But there would be a possibility also under such an entity to pull in public purchasing as well. And the last item for your consideration in our pooled purchasing discussions that we discussed was the option of creating some kind of public health pooled purchasing model for chronic disease drugs. This would be simply, the concept here would be to simply carve out certain drugs altogether and then purchase them under an arrangement similar to vaccines for children or Wisconsin's own chronic disease program. We felt that this program would be most feasible if we focused on a specific condition or set of conditions and the drugs used to treat those conditions, and in particular chronic conditions due to their known statewide impact and both in terms of health and cost. This, of course, would be considerably costly, and there's many administrative challenges, but this option could also provide the most holistic coverage approach for all people who have interest in this issue. So that concludes the remarks that I have prepared. My contact information is on this slide if anyone wishes to reach out, but I will pause here for any questions.
Sounds good. Well, thank you, Renee. Really appreciate that overview of the work of the committee. In the interest of keeping us on time, and since we have 4 more presentations, I think we're going to skip questions today, but what we'll do is send around the full report to the task force members after the meeting today. And then I would encourage anyone, if you do have any follow-up questions, to reply, send them back to me, and we can follow up with Renee and her team to get any answers after people have had a chance to look at that report in more detail. So thanks again, Renee, really appreciate it. And we will we'll send any questions along to you in the coming days and weeks as we get them.
Great, thank you.
Sounds good. Okay, thanks everyone. So I know there were a couple questions on that as a follow-up to Renee's presentation, but like I said, please send those as a follow-up after we send the report, and we will make sure we get those answered. Just want to make sure we keep things moving along today, given we have a full agenda. So moving on, we're now going to hear a presentation from the Northwest Prescription Drug Consortium. So Trevor and Donna, I will turn it over to you.
Great, thank you. Trevor, are you able to hear, or we can't hear you if you're talking?
There, you should be able to hear me now.
Great, thank you.
Well, thank you very much, members of the task force, for having us. We appreciate the ability to present to you today. So I'm Trevor Douglas. I'm the Director of Pharmacy Purchasing for the Oregon Health Authority and the Director of the Oregon Prescription Drug Program. And with me today, I have Donna Sullivan. Donna, go ahead and introduce yourself.
Sure. Hi, I'm Donna Sullivan. I am the Chief Pharmacy Officer for the Washington State Healthcare Authority. We manage our state Medicaid program as well as our public employees' health benefits.
Perfect. Next slide, please. So in the next, I think we have 40 minutes. We hope to provide you with an overview of what the consortium is and what our offerings are. I think it's important to just call out that this interstate agreement exists between the states of Oregon and Washington because of enabling legislation. I'll go over a little bit of the history in a moment. But before we do that, I want to let Donna touch briefly on the array of services that we have to offer to meet the needs of both the public and private entities that we serve. So go ahead, Donna, next slide.
So the Northwest Consortium has many services similar to what was just presented. We work with our Department of Corrections, our state hospitals, our public employees programs, our Medicaid programs, and a discount card. So we have a group pharmacy benefit management contract for commercial health plans. Currently, our Washington State Uniform Medical Plan uses that pharmacy benefit management contract. It's fully transparent, and we'll talk more about that later. We have a managed Medicaid pharmacy benefit administration option as well. We have one plan in the state of Oregon that is participating. Both Washington and Oregon have a discount card where the discounts that on prescription drugs are the same as we have negotiated for our health plans and the pharmacy benefit management contract. We have a GPO contract, which is used by our Department of Corrections as well as the Oregon State Hospital. We have a voucher program, which we'll get into a little bit more later, but it allows emergency prescriptions at Department of Corrections or prescriptions upon discharge or release from the hospital or from a correctional facility. We have a 340B program administration that is coming. We have rebate administrative services only. So our Department of Labor and Industries, they're able to submit claims and get rebates on some of their claims, although they're not using the pharmacy benefit manager that we've contracted with. We have a Medicaid supplemental drug rebate program that we're trying to establish, and that'll be coming in the future. And then we also are developing a fee-for-service, a state-run fee-for-service Medicaid solution for state programs, and that also is coming in the future. Next slide.
So as I mentioned earlier, I was going to touch a little bit on the history. So I'm not going to read through all of the fine print here, but I'll just hit some of the high points. As you can see, Oregon Prescription Drug Program was established in 2003. Likewise, Washington's program was established in 2005. We came together in 2005 and in 2006 issued an RFP via Oregon's Office of Procurement, and that competitive process saw Moda Health elected to be the administrator of the consortium's programs. Moda Health is a health insurance company in the state of Oregon, and works with us extensively to develop our program and enhance it year after year. In 2010, we issued a second RFP from the state of Oregon and in cooperation with Washington, and expanded the scope of services to include Medicaid, Medicare, the GPO element, and the 340B programs. And again, Moda Health was selected in that competitive process. We then again, in 2016, conducted another RFP and again, Moda Health was renewed as the program administrator. I point this out just to demonstrate to everybody that we routinely go out to make sure that we are, keeping pace with the market and making sure that we push forward on our mission to deliver the best cost and most cost-effective solutions for our entities. Finally, in 2019, we issued the last RFP, and we're able to again announce today that we have tentatively awarded that RFP to Moda, and we're currently in contract negotiations. So we don't want to say too terribly much, but that's where we're at. And where are we going? Don will touch on this a little bit later, but I think it's just important to note that we continue to grow. We are adding Washington's School Employee Benefits Board to our groups. We also have a couple of small groups that are joining in Oregon and expanding. I think we're almost at 120,000 additional lives for 2020. So that's a big success. All right, now that we've addressed that, let's go to the next slide. So I just want to kind of get a lay of the land here. We're going to go through each one of these boxes here across the page. And I just kind of wanted to make sure that we all understood that the consortium oversees each one of these programs in conjunction with the program or the entity that we're serving. So there may be self-insured groups, there may be government agencies that require PBM services. Those are overseen by the consortium, but the participating entity drives the conversations and gets the services that they need from our programs and our administrator. Likewise with all of the other items, with the exception of possibly the discount card program, because that is an individual program, which we'll touch on later. So without further ado, let's launch into the pharmacy benefit management services, and Donna will walk us through that slide.
Sure. Thanks, Trevor. So our pharmacy benefit management contract, it's a pure pass-through pricing contract, meaning that the amount that the pharmacy receives is the same amount as what is billed to the health plan. So there is no spread pricing. And we have not allowed spread pricing since the initiation of the consortium back in 2006. We also have 100% pass-through of all manufacturer rebates and fees. So the plans do receive 100% of those funds, and we're able to fully audit those contracts. So we're able to reach into the manufacturer contract, look at the pharmacy benefit management manager's contract. We also can look at the pharmacy contracts. So we have full audit rights of our programs, which is not typically seen in the pharmacy benefit management arena. And then we also provide annual market checks. So each year we contract with a third party to compare our rates to other similar health plans across the country, and to ensure that the rates that we're negotiating with our pharmacy benefit manager are competitive with others. And if the rates are not found to be competitive, we immediately enter into negotiations and we'll renegotiate our prices. So the Moda Health is the pharmacy administrator. They contract with a pharmacy benefit manager to provide some of the services. The services that are provided, there's member services. We have the claim processing services, clinical services such as prior authorization, development of a formulary, other utilization management services. The Moda and our PBM, they negotiate the rebates directly for the consortium, or we can use their book of business rebates as well. They do the pharmacy network management and negotiations of who's in and who's out of the network. They do the billing, invoicing to the different programs, and then they help us with a pretty robust reporting and analytics process as well. And you'll see that we have the benefiting agencies that oversee the entire program. So the consortium really is the two states, and we have a steering committee that meets to oversee the services that are provided. The administrator, as we mentioned, is Moda Health, and then we have various participating programs within both states. So, next slide.
So I'll touch a little bit now on the discount card program. Donna did a good job of teeing this up in the introduction, but I think it's just really important to illustrate that none of the purchases made under this program are subsidized by state funds. This offers individuals that are citizens of Washington State and Oregon State to the comparable pricing that the participating groups get under the consortium. And they can use that discount card anywhere in our pharmacy network nationwide. And so I will touch more a little bit later on how the savings works, and I'll give a breakdown from last year and then a total savings picture from the inception in 2006. That'll be a little later. So I think we'll move to the next slide where John will touch on the GPO element.
Okay, so talking about the GPO option, it's a state-backed GPO program, and we've contracted with 2 different GPOs. One is Premier, which is through a hospital system in Northern Washington, and then we also have a relationship with MMCAP Infuse, which I think you're more familiar with. The GPO program is used by Washington State Hospitals, Oregon State Hospital, our correctional facilities in Washington State, and then other public programs are able to participate in the GPO. The services are provided at a national level. We have aggressive class of trade pricing for our public entities. Again, we do regular market checks to ensure competitiveness of the GPO program itself. And for the government programs, there's no affiliation fee to join the GPO. And I think that's next slide.
Well, Donna touched on this beautifully as well. And the voucher program is a unique program that the consortium has developed. And what we found is oftentimes there's folks that come into an institution that might be justice involved, so a jail or a prison, and they need a medication that might not be immediately on hand, so they need to procure that as quickly as possible at a retail site. So they issue a voucher. That voucher is then taken to that pharmacy and locally, and then that prescription is filled and then returned to the institution to be administered to the patient. That is in place of going directly to the pharmacy without a voucher and paying usual and customary. So there is a significant savings because the negotiated rate that we have negotiated as a consortium applies to the voucher program as well. This is typically a one-time access to the prescription at a retail pharmacy. And the way that this works for state hospital discharging patients is a voucher is issued to that patient. That patient goes to the community where they're going to reside and then is able to go to the pharmacy, fill their prescriptions, and not have to worry about paying. So it helps with compliance and making sure that there's also less waste for those that may not fill or may not take a prescription that was issued to them upon discharge. I obviously already touched on there would be significant savings over the UNC price, which is typically how many organizations, particularly jails, access medications. They will go to a neighborhood pharmacy and pay the usual and customary price to fill a prescription that's needed by a justice-involved individual. So this is a valuable program, and we also have a hospital that has a readmit program that uses our voucher program to make sure that maintenance meds are filled so that the person doesn't readmit into the hospital right away within a week. And so it's also been a very successful program for a hospital that is in Salem. Next slide, Donna will talk a little bit about the Medicaid fee-for-service program that we're pushing out.
Right. So we've talked with many state Medicaid programs, and there really is a desire to have like a state-run solution for Medicaid. So Trevor and I have decided to try to lead an effort to create a fee-for-service Medicaid solution that is really transparent and really state-focused. And some of those services that we'll be looking at will be, providing the full scope of services from member services to reporting, processing the federal rebates, developing a supplemental rebate pool, and really, even driving towards, a single PDL potentially across several state Medicaid programs where we can try to really leverage our our purchasing with those supplemental rebates through a single states coming together to use the same preferred drug list. And that's with the rebate pools that are out there right now, that they do have the supplemental rebates within the pool, but many of the states still have their own unique preferred drug lists, which I think kind of separates and weakens those particular programs. But really what we'll be doing is we'll be working with several of the pharmacy directors across the different states and developing the requirements of what would be like an ideal solution for a Medicaid fee-for-service program. And we're targeting January 2023. Washington State will be releasing a request for proposals for a new, our point of service program for fee-for-service. And so we're hoping to align the consortium to be able to bid on that particular business. And next slide.
Thank you, Donna. So we heard a lot about transparency in the previous presentation, and I appreciate that setup. The consortium is very proud of our program and the work to make our offerings better every year, and strengthen our contract language as it pertains to true pass-through and true transparency. Over the 14 years of delivering these services, we've continually improved that contract language and have been able to deliver true pass-through pricing, essentially and effectively eliminating any spread. We also have true pass-through on rebates. This includes even the administrative fees that are paid by manufacturers to a PBM at times, directly back through to the program. We do all of these things for a fair, fixed administrative cost. And that is really key because that brings a predictability to the administrative budget. Again, we include that annual market check, which impacts all of the groups that we serve and protects them to make sure that we are competitive within the market. We routinely, and we'll demonstrate this later, outperform our guarantees. And that's, you know, the essence of a true pass-through contract. When a guarantee is stated and we exceed that, that benefit is passed directly through to the participating entity. That's transparency. And we know that this happens because we have the ability to audit at the claim level. And so we have the ability, as Donna mentioned, to do robust auditing, and you know, we hold our contractor and our subcontractors accountable. Next slide, we'll start to get into some of the examples and the experiences that we've had, and I think Donna gets to share the first piece of good news.
Yeah, so in our public sector employees program, this kind of demonstrates the value of the pass-through pricing, where we have looked at repricing analyses of other employee groups that are interested in joining the program. We've repriced over 2 million claims. We've looked at the allowed amount that that particular group paid, and we compared that to what the consortium would have paid. And so you can see with the one employee, public employee group, that our savings with this particular program was close to $10 million, where they would have paid that much less in drug costs, so about 4%. We also have repriced managed Medicaid programs, saving them potentially over $2.8 million, and other small commercial group, $39,000, which might not seem significant, but for small employers that could be quite significant. We've also repriced the Washington State Medicaid managed care plans, which is not reflected on this particular slide, but it showed that even with the consortium, if the managed care plans had used those contracts, we would have saved $84 million per year in just the cost of the drugs alone. And I think what that really demonstrates is that difference in the spread pricing. So you might look at the reimbursement rates and what those are negotiated in the contract, those might be the same, but when you look at the difference in savings at the end of the day is really that spread pricing and not allowing that to occur. So Trevor, I think you're up on the next slide.
Yeah, thank you. So as I mentioned, we have true pass-through, and what that means for existing employer groups is illustrated here. And you can see by looking at each of these entities, the column that's the guarantee amount, and then what the paid amount is, and then the delta, is the next column, which is the savings. And so, although the guaranteed amount is what the contract says, the actual paid amount is reflected here, and that savings was passed through at the point of sale to each of these groups, and in turn that basically returned a great deal of savings, ranging from 2% to almost 9% of additional savings, which effectively and essentially eliminates the spread. So next slide, we'll talk a little bit about the discount card program. So I mentioned before, this is a state-sponsored discount card that isn't subsidized, and individuals can register for this card and utilize this when perhaps they may be facing a lapse in coverage, or maybe a large sizable deductible and are near the end of their plan year and wish to forego paying the deductible and use this discount card to pay a lower cost. Essentially, in 2019, we filled just shy of 300,000 prescriptions across both Washington and Oregon. And that translated to almost basically $2 million in savings almost for both states on a monthly basis. So quite impressive and well received by the public. The other column is just a fun fact, and goes over the entire experience from February of 2007 through December of last year. Just for your knowledge. So where do we go from here? Donna's going to take us in the next slide through some of the future prospects.
Yeah, and I just want to chime in a little bit on the discount card. So unlike other commercial discount cards, there's no annual fee to join the discount card program. And also, we only collect a nominal fee to cover our administrative costs. So there's no profiting from the states off of the prescriptions that are being delivered to those using the discount card. So then going into future directions, it was touched upon with Renee and her discussion about and there was a question about how do you control prescription drug costs. I think that really the way to do that is we need to disrupt the supply chain, and the Northwest Consortium is fully committed on doing that. We're looking at soliciting participation and growth from other states, which allows us to kind of have that bargaining power, but really looking at the supply chain, looking at fulfillment, possibly becoming a wholesaler for the entire state, and where the pharmacies can actually purchase drugs, have the state negotiating what those drug prices are, and even then negotiating directly with manufacturers on certain drugs. We're also looking at that public health model, looking at the Washington Vaccine for Kids program, where can we purchase insulin that way? Volume purchasing on insulin and get it to patients that really need it. So we're having lots of those conversations in Washington and in Oregon, and we're trying to figure out how the consortium can support those.
Thank you, Donna. So next slide talks about how Wisconsin can join and partner with us. So essentially, we've been asked by quite a number of states now about how they could work with us and either participate or be a partner. And so what we have here is a matrix that tries to help guide states in how they might participate or partner. As I mentioned early on in the presentation, both Washington and Oregon have statute that enables us to participate with regional consortia, and thus we're able to establish an intergovernmental agreement between the two states. And we're currently in discussions with another state to establish another intergovernmental agreement. And that would translate into either a participation agreement or a partner agreement based upon what we're doing. So if they're wanting to be a partner and fully participate in the consortium activities, really we would need to have like statutory authority in that respective state. If there was no statutory authority, then we would be able to contract to deliver to a state agency or a state entity's needs, but there would be limited participation in the consortium's activities and business operations. And so I can tell you that we're excited as the consortium to welcome new states and welcome any engagement from Wisconsin to explore the possibility of working together and partnering as sibling states. And Donna wants to summarize what we've covered today, and then we'll probably have time for some questions.
So next slide. Thank you. So the Northwest Consortium really is a purchasing collaboration. It's really designed for public and private partnership. Washington and Oregon both have enabling legislation that allows us to work together with other states as well as other private purchasers. Again, it includes solutions for, again, public and private pharmacy benefit management. It also includes a solution for a workers' comp program in the state of Oregon. We have a Medicaid, managed care, and fee-for-service solutions that we're working on. We're working on group purchasing for our facilities and other correctional agencies across the states. We will continue with the discount card. So for the uninsured or underinsured, they can get real discounts on their medications. We are really seeking to partner with other states. We have some states, several states that are asking more about joining the consortium. We're hoping Wisconsin will continue to be one of them. And as we grow, as states join and grow, we're always adapting to whatever solutions that they need. If they need a new program or something, if they have a new concept, we do whatever we can to adapt to meet their needs. And then we can offer those programs across all of the states within the consortium. And the states, if you're participating, you don't have to participate in everything. Not all of your agencies have to join. We first started in Washington with just our public employees program, and we've grown it now to include the Labor and Industries, Department of Corrections, our state hospital, and now our school employees program as well. So again, you can come in small and grow over time, or you can, any state can come in with any of the programs that we have services to offer for. Next slide. And I think this is just our contact information. If you have any questions, feel free to reach out to Trevor or myself. We're more than happy to jump on a call and answer any questions you have. And I think we have time for questions if the agenda allows for it.
Mm-hmm. Yes, well, thank you, Trevor, Donna, thank you. Really appreciate that presentation. I know we had heard a presentation from you as well with our work on the Pharmacy Cost Study Committee, but also thought that there would be value in having this task force also hear about the consortium. So thank you for being here today and taking some time to give us that information. I know we do have a few questions and we do have a little bit of time. So there's a question here. I saw Yolanda posted something about how does your discount card program differ from other discount card programs like GoodRx and others?
So I can take that question, and Donna, you can fill in if I miss something. Well, I've actually done quite an extensive amount of research on other discount cards, and I'm happy to share that most often our discount is superior to other programs. The exception being those discount cards that have a managed element to them, i.e. they prefer a specific drug or have a relationship with a manufacturer that allows them to maybe offer an introductory prescription at a much lower cost, but then subsequent prescriptions maybe lose a coupon, and then that patient is then paying an amount that is more than they would otherwise on the prescription drug discount card that we have. I'm not going to say that absolutely every drug is a better deal on our discount card, but most often it is. And we routinely tell consumers when they're enrolling for our card, please don't throw away your other discount cards. Be a prudent consumer and compare. And that has led to a lot of success. We even have state employees that register for this card because, as you might be aware, there are medications that are not covered under public employee benefit plans, and those medications can be covered in terms of a much lower cost to an enrollee through the discount card program. So a lot of use, and sometimes there's a medical need for a cosmetic medication. I tell this story all the time. There was a young lady who was suffering hair loss, 6 years old, mother, state employee, unable to afford medication, Latisse, to grow eyelashes, saved her literally 50% of the cost and was able to buy this for her daughter. So lots of success stories like that.
Great. Thank you for that information. Josh, I believe you have a question, correct?
Yes, thanks, Nathan. Thanks, Trevor and Donna. Appreciate the information. Josh Bindle, CEO of National Cooperative RX here in Wisconsin. So we are similar to you in that PBM Purchasing Coalition, we're not for profit, although you do many more things than we do. So kudos to all the things that you do. And our model is still spread. We've seen the most value out of that. You guys are transparent. That's great. Wanted your perspective on coupons, how your program works with coupons, and then also rebates. You talked about full pass-through. Are there groups that are fully passing through to the consumer, or is it passed through to the plan?
I think I can take this one, Trevor. As far as coupons go, coupons are really a challenge for health plans in general. We are not doing the adjustable copay and with the patient accumulators at this time. Most of the programs, if the coupon is being used, the value of the coupon is really being, it is to the consumer, not to the plan. The coupons really are a way to kind of get around any patients or any plans kind of formulary options. So what we're seeing and what our Uniform Medical Plan has done for state employees and school employees, we've gone to a closed formulary so that coupons can't be used to get a drug that's non-preferred unless there's a prior authorization that, and it's determined that that non-preferred drug is medically necessary for that particular patient. And then if that drug is approved, they have the preferred coinsurance. So we're really trying to battle coupons because they do subvert the utilization management and formulary management process. As far as it comes to rebates, we have the ability, I believe, to pass the rebate through to the consumer. However, I don't believe any of the programs have currently chose to do that at this point in time. Trevor, I'm not sure if any of the Oregon programs have done that as well.
No. Yeah, very similar dynamic. We have the option, but nobody's elected at this time. Doesn't mean somebody wouldn't in the future. Would you have any per covered life per year metrics that you could share, either before rebates or after rebates or both?
I think we probably could come up with some numbers. I don't have them off the top of my head, but we probably could come up with some of those figures.
Okay, thanks.
Okay, great, thanks. Brian Stevens, you had a question?
Yes, Brian Stevens, CEO of York County today. Hopefully, Trevor and Donna, really impressed with the work that you've done. Any policy makers?
Ryan, we're having some challenges with your
either
audio.
of your two states have success and tried to, legislate. Okay, I had the question real quick. Just curious if the policymakers in Washington or Oregon have been able, with respect to spread anything like that, putting legislation in place that would affect employers and others in those states.
Don, if you heard better than me, go ahead, but I am at a loss to know how to respond to you, Brian. I cannot hear you.
Brian,
I'm sorry. I apologize.
I think what I heard you ask was whether or not the state legislators or policymakers are considering legislating around spread pricing. Is that accurate?
That's correct.
To my knowledge, I don't know. It is something that we are putting into all of our state contracts, but I'm not sure to what extent the legislators will be putting forward legislation on spread pricing. I know that they have other legislation around pharmacy benefit management regulation, like not allowing gag clauses in a contract between a pharmacy benefit manager and the pharmacy, where it prohibits the pharmacy from telling the patient that their copay is actually more costly, is more than the actual cost of the drug itself. There's all kinds of other regulations that are being introduced in Washington. Most of them aren't passing, but spread pricing, I don't believe, was one of those.
Thank you. Sorry about the bad connection.
It's okay. And in Oregon, I just want to add, very similar. There was some legislation passed in 2019 regarding PBMs and them not allowing to force members to use a specific type of pharmacy, i.e. a mail order pharmacy. That piece of legislation, I believe, sunsets at the end of next year. So I think they have to revisit that within the next session. So lots of moving pieces in Oregon too. So more fun in the long session in Oregon next year.
Great, thank you. I think we have time for one more question, and it looks like Dr. Goldrosen typed something to the effect of, are there already other states participating in the consortium in some way? I know you had touched on that, but is there any additional information you could provide, or Dr. Goldrosen, is there any more context you want to provide to that question? Okay, well, Trevor, Donna, any additional information you could provide about participating states that are participating?
I think at this time, what we can say is that we're currently talking with a number of states. I think it would be unwise to kind of like this, start sharing with everybody who we're talking to, but we're all, and they seem to all be at varying stages, but some that are showing great promise with respect to moving forward. And those span from both coasts, the middle of the country, and even entities that don't call themselves states but territories.
Well, thank you both. Appreciate you being here, providing this information. I'm sure we will continue talking. in the weeks and months to come. Definitely interested in learning more about what you're doing and exploring, possible opportunities for partnership in the future. So thank you both.
Great.
We welcome that. Thank you for the time.
Okay, well, so far we're still on schedule, so that's a good thing. So we will turn it over to our next presenter. We're going to hear a couple presentations from a couple different consumer advocacy organizations, starting with AARP. So Leah, will turn it over to you. Oh. Leah, I think you're still muted.
Yeah, I hit it a few times and apparently it didn't work out. I apologize. My name is Lee Purvis and I am with AARP's Public Policy Institute. I am responsible for AARP's work around prescription drug policy, which a lot of people like to shorten to telling everyone that I do drugs. And I am here today to kind of give you a better idea of what it is that really is driving AARP's work on this, and also its efforts around this issue and some solutions we've been paying attention to. Next slide, please. One more time, sorry. One more slide. Thank you. Okay, so the first thing that I always like to point out is really how much prices have increased. I think we're kind of the frog in the proverbial pot of boiling water. And so what I always try to help people understand is that the prices that we're seeing when drugs come on the market really have gotten remarkably higher. So when I first really started working on this issue, I found a whole bunch of articles about 30 years ago where people were in an utter outrage about the fact that there was a drug coming on the market that cost $10,000 per year. And frankly, that price seems kind of quaint in a world where we are now seeing drugs entering the market with prices that exceed $1 million. We have seen an incredible amount of price inflation over the past decades, and it really has become where we've switched from asking people to purchase a reasonably priced used car, which I think a lot of people would already say is too much, to buying a mansion. And a lot of times we're asking people to make these purchases year after year. And that frankly is just not something I think that anyone can afford. Next slide, please. Something else that we've really been keeping an eye on is the fact that we are seeing more and more of these expensive drugs. If you take a look at what drug manufacturers are focusing on, they are focusing on drugs that can command high prices. So if you look at what FDA approvals have looked like over the past 10 years, roughly half of those drugs are specialty drugs, so those high-priced drugs that you often hear about in the headlines with those six-figure price tags. We're seeing more and more of those drugs going through the FDA approval pipeline. We're also seeing a lot of emphasis on biologic drugs, which are different from traditional drugs in the sense that they are derived from living organisms instead of chemicals, and they do tend to come with a significantly higher price tag. We're seeing a lot of emphasis on orphan drugs, which are drugs that are used to treat patient populations that are considerably smaller, and a lot of also ultra-orphan drugs, which you can have a patient population of less than 10,000 patients. Typically, drug manufacturers use that type of patient population to justify a considerably higher price, on average around $150,000 per year. And then of course, we're seeing a lot of emphasis on personalized medicine, which of course is very important, something that we all want to move towards. But again, those types of products can command a much higher price. Next slide, please. And of course, unfortunately, high prices when they come on the market really is just the beginning. If you take a look at really any newspaper, you are going to see some evidence of drug price increases, and they are considerably higher than inflation. AARP has been tracking prescription drug prices since 2005. We have been seeing pretty much the same story year after year, and what we're seeing are price increases that exceed inflation by twofold more than 100-fold in the brand name drug market. That obviously means that their prices are growing much, much faster than the prices of other goods and services. And something else that we've noted is that you often get a one-time outrage. We see a lot of people focusing on that one-time 10, 20% increase, and then the outrage kind of goes away. But what we don't necessarily focus on is exactly how those price increases can compound over time. And that's something that AARP has been focusing on lately as part of our long-running pricing track series. So next slide. One great example is brand name prescription drugs. We took a look at how prices have increased within a group of widely used brand name prescription drugs. And what we found is that the average annual cost for just one brand name drug would have been more than $5,000 lower in 2017 if those price increases had been held to inflation. That obviously is a huge and meaningful impact on the patients who are taking these drugs. And if you take a look at this graph, you can see exactly how those price increases, again, compound over time. What might be, frankly, an outrageous price increases one year, if it continues year after year after year, that really does make a big difference over time. Next slide, please. This is even more obvious for specialty drugs. We also tracked the prices of those high-priced drugs and found that, again, that price could have been $50,000 lower in 2017 for the average annual cost for one of these drugs. Again, a relatively small increase can lead to a very big price increase when you're already talking about a high-priced drug, but this has a huge impact both on the patients and for the people who are paying for these drugs on the payer side. And so, again, going back to this idea that, yes, one price increase shouldn't be happening, but price increases year after year after year really do have a big impact over time. Next slide, please. So now I'm going to kind of jump into why is AARP here? Why does AARP really care about the topic of prescription drug prices? Next slide. I think the one thing that tends to get overlooked is that older Americans use a lot of prescription drugs. In fact, they use more than any other segment of the population. So when you look at Medicare Part D, you find that on average, they're taking over 4 prescription drugs per month. And they also tend to take them for chronic conditions. So we often like to point out, this is not just a one-time cost for the people that AARP represents. This is an issue and a cost that they will be facing every single year for the rest of their lives. Another common misperception that we face is that Medicare beneficiaries and older adults are frankly flush. The reality is the median income for people who are in Medicare is just over $26,000 per year. If you take a look at that number and you think back to those prices that I was just talking about, that obviously is not something that they can sustain. You also have to keep in mind that they may not have a lot of savings. 1 in 4 have less than $15,000. There is really no way for older Americans to be able to absorb the costs that are coming with high and growing prescription drug prices. Next slide. AARP is also kind of unique in the sense that we not only are focusing on our members, but we also take a lot of interest in the programs that they rely on. And that usually means things like Medicare. So Medicare Part B is in boy, which covers outpatient prescription drugs that are administered in a physician's office. Spending under that program has more than doubled between 2005 and 2017. It's also important to keep in mind that Medicare is not quite as generous as a lot of people may think. Medicare beneficiaries using drugs under Medicare Part B are responsible for 20% of their prescription drug costs, and there is no out-of-pocket cap. So there are beneficiaries who are facing annual costs that exceed $100,000 if they are on those remarkably expensive drugs. Again, going back to the income, going back to the savings, going back to frankly anyone, there are very few people that would be able to absorb or pay for those types of costs. Medicare Part D is in DAWG for outpatient prescription drugs that you pick up at the pharmacy counter. Spending under that program, total spending is approaching $150 billion per year. Medicare Part D is also kind of the canary in the mine in the sense that they are using a lot of co-insurance where beneficiaries are responsible for a percentage of the drug's price. That means that beneficiaries are really impacted directly by drug manufacturers' pricing behavior. Co-insurance under Medicare Part D, there is a limit, but it's 50%. If you're talking about drugs that are well into the thousands of dollars, that's not really a cost that most people can afford. Medicare Part D does have an out-of-pocket limit, but what a lot of people don't necessarily understand is that that out-of-pocket limit is not hard. It's not a hard limit that I think a lot of people are accustomed to. Enrollees are still responsible for 5% of their costs even after they enter a catastrophic coverage. And that has led to some enrollees facing costs that approach $10,000 per year. I keep going back to the income, $26,000 per year. This really is not something that is sustainable. And of course, we're also very focused on the Medicaid program, given current events and frankly, what was happening prior to the current pandemic. State budgets are under a lot of stress, and it's really becoming a question of, do you pay for state programs or do you pay for other things? And unfortunately, prescription drug pricing trends are pushing and causing a lot of stress on those budgets. Next slide. We also are very cognizant of the fact that a lot of our members have private coverage. We're seeing under employer-sponsored plans a lot of trends that we've already seen under Medicare Part D. So we're seeing a lot of plans that have a fourth or even higher tier of cost sharing. On average, their copays for a fourth tier drug, usually a specialty drug, is over $100. The average coinsurance is around 29%. We also are seeing a lot of plans with high deductibles. If you are talking about several $1,000s per year, that is not something that a lot of people can afford. We do have out-of-pocket max under private coverage, but look at these numbers. I don't think that anyone on this call would be very interested in spending $8,000 to $16,000 every year. So it really does present a serious financial hardship if someone is taking an expensive prescription drug or frankly, a lot of prescription drugs. Next slide. The one thing that I really want to make clear is that the problem here is not the cost sharing. High cost sharing is definitely a problem. We don't want anyone facing cost sharing that makes it impossible for them to afford the prescription drugs that they need. However, cost sharing is just frankly an indicator of the underlying problem. And if you only address cost sharing without addressing that underlying problem, which is the price, it really just turns into cost shifting. And ultimately, those costs will come due when in the form of higher premiums or higher costs down the road. The other thing I want to kind of point out, because I've always found this interesting, a lot of the drug manufacturers are the ones who are pushing the mantra that the cost sharing is the problem. And what I've noticed is that a lot of the time when it is high cost sharing, it is related to coinsurance, and it is a relatively small percentage of that price. So if they are complaining that that relatively small percentage and the cost associated with it is too much, what are they actually saying about the full price of that product? Because that is being paid by the system. So again, I just want to be clear, nobody likes high cost sharing, but if you really want to address the problem and you want to get that cost sharing down, you need to address the price of the products that are driving it. Next slide. Something else that we hear about a lot are drug manufacturer programs, which really are helpful. To the extent that there are people out there who simply cannot afford their prescription drugs, these programs can be a godsend. However, they typically have pretty strict eligibility criteria, and those criteria can vary from drug to drug, even from the same manufacturer. And it is a frankly complicated process. So patients do have to jump through a fair number of hoops. They do have to meet, again, those strict eligibility criteria. The idea of a copay coupon, which I know has been mentioned earlier, again, very helpful for people who are facing those high costs, but that ultimately does lead to higher premiums. And the one takeaway, I think, from these programs really is, why are manufacturers putting so much effort into making the system even more complicated rather than simply dropping their prices? Next slide, please. The one takeaway that we have on pricing is that this is an issue that touches absolutely everyone. You are either paying as a patient at the pharmacy counter, you're paying as someone with healthcare coverage through your premiums, you're paying as a taxpayer because taxpayer-funded programs pay for prescription drugs. The shorthand way of looking at it is that every single person on this call is already paying for prescription drugs, even if they aren't taking one themselves. Next slide. So next, I'm going to kind of jump into some solutions that we've been taking a look at and are getting a lot more prominence in the hopes that they might trigger some ideas. So next slide, please. So I provided this because I really do want to make it clear that this is an issue that resonates across all boundaries. If you take a look at the public support for some of the ideas that have been floating around lately, you're looking at approval support in the 75 to 90% range. I don't think there are too many things in this country that this many Americans agree on. This is an issue that really is important, and consumers really do need help. And there are a lot of ideas out there, but again, this is not an issue where you can go wrong if you help bring down their prescription drug costs. Next slide, please. So I'm going to start at the top in terms of what's been happening, recognizing, of course, that this is federal, but I think there are a lot of themes that you can take away from what's happening both with the administration and with Congress that I think are helpful in thinking about potential ideas for addressing this issue. The one thing I think that's worth mentioning is that the administration has been very engaged on this issue. If you take a look at this timeline, there are a lot of ideas out there. Unfortunately, they haven't had quite as much success in terms of actually fully implementing these ideas, but it does give you an idea of exactly how much it has been recognized that this is an issue that really demands some action. And you can see that in the amount of work that they've been putting into it over the past few years. Next slide, please. One topic that they have worked on a great deal and may in fact be working on again that I think is worth raising because I've been seeing this both at the state and the federal level is the idea of rebates. The administration proposed something under Medicare Part D that would have effectively eliminated rebates, would have allowed point of sale rebates, but it was effectively eliminating rebates. There was a lot of attention paid to this idea, but what was ultimately found by the Congressional Budget Office is that this idea would actually increase spending by approximately $200 billion over 10 years. It also found that premiums would increase for all enrollees. It was also very unclear exactly how many enrollees would have an actual meaningful reduction in out-of-pocket costs. You take a look at the numbers on this slide, you can see that a lot of Medicare Part D drugs do not have a rebate. And of those that do have rebates, they may not be substantial. Also worth noting that a lot of those high-priced specialty drugs that have been getting so much attention in terms of affordability do not have rebates. So I think it's important to keep in mind exactly how effective the idea of toying with rebates will be. I think it's also really important to keep in mind that drug prices will not change under efforts to address rebates. In fact, several major manufacturers were asked during the debate over this idea whether they would reduce their prices if they no longer had to pay rebates, and none of them would commit to doing so. So again, there's some very large implications of going into this space. And again, the reason I'm raising it is because I have been seeing and hearing this discussion taking place at a lot of different levels. So it's very clear, even though the administration ultimately withdrew this proposal, that we will be seeing it again. Next slide, please. There was also a lot of effort in Congress prior to the current pandemic, a lot of hearings, a lot of legislation. I think the one theme that I would hope everyone would take away from this is an emphasis on behavior that frankly is inexcusable. If you're hearing about abuses on the patent side or making it impossible to get generics on the market, those are the types of things that really resonate with policymakers and frankly with consumers, because there is really no way to justify some of the issues that were ultimately kind of under consideration in Congress. And I think that's something to keep in mind going forward is, unfortunately, there is a lot of material to work with when it comes to drug manufacturers' bad behavior. And that, again, is something that really can resonate and something that does have a meaningful impact. Next slide, please. Again, going back to this theme idea, there are two big, so to speak, pieces of legislation that are still out there that were considered, and a lot of them focus on two things. One is trying to bring down out-of-pocket costs. The legislation you're seeing here is more focused on Medicare, but the idea is one that I think really has resonated, and it's trying to find ways to limit out-of-pocket costs. The second really big part of these bills is that they wanted to address those prescription drug price increases that I mentioned earlier, finding ways to encourage drug manufacturers not to engage in that type of behavior. So again, some ideas on some themes that we've been seeing at the federal level. Next slide, please. This is also very interesting because it has occurred post-pandemic. And a lot of legislation has been specifically focused on COVID-related drugs. And what they are trying to advocate for is ensuring that if taxpayers have put forward a considerable investment in a product, they should not be charged high prices. it's highlighting a lot of challenges within the system. It's trying to improve transparency. But what's interesting about it is these are ideas that have been floating around for quite a while and could certainly be broadly applicable. So we're keeping an eye on this because of those larger implications, but it's highlighting some issues that have been around, again, for a while in terms of taxpayer investments and lack of transparency. And this is something that I think, frankly, will be going around going forward. Next slide, please. And of course, as you all well know, the states have been incredibly active, and we've been seeing a lot of different bills and ideas and legislation that have been focusing on trying to bring down prescription prices and prescription drug costs. And I think the reality is, going back to the state budget, states don't have a choice. They need to balance their budgets. And in the absence of the federal government being willing to do anything, this really is an opportunity for states to step in with some innovative ideas that try to address the challenge. And I'm going to go into a little bit more detail on some of these ideas, but broadly, the ideas are focusing on, bad manufacturer behavior, trying to combine as many purchases as possible to really increase the leverage at the bargaining table. And then transparency, I think, is also something that's been incredibly important. Next slide, please. So speaking of transparency, this is definitely kind of a monster of the drug industry's own creation, in the sense that they have spent a very long time and a lot of money arguing that the prices that they have set are justified by things that we cannot see. It's very difficult to verify exactly what drug companies have been telling us in terms of their research and development and how much they've spent bringing these products to market. We don't have the ability to look further into those numbers that they're providing us with, and that has made it very difficult to push back on their pricing decisions, because frankly, we don't know what's behind those decisions and whether those decisions are justified. And that is something that transparency is trying to address. It's trying to look a little bit further under the covers, saying, okay, well, can you at least give us the information? Can you at least verify what it is that you're telling us? Can you provide something to substantiate the arguments that you're making? And what we're seeing some states do is take a step further and actually use that information and try to drill down and figure out whether drug prices are in fact justified. And those are the affordability review boards, where they take the transparency information and take it a step further and use it and say, okay, yes, we agree with your pricing decision, or if there is an issue, that try to find a way to resolve it. Next slide. You've heard this a little bit earlier. There is a lot of interest in prescription drug importation. This is another issue that has a great deal of public support that has been around for quite a while. It's gotten kind of some renewed interest because there's a lot of narrative coming from the current administration that's been highlighting kind of free riding, or the idea of fairness. I think the American public at this point is fairly well educated in terms of exactly how American prescription drug pricing differs from pricing in other countries, and how they do pay considerably more for brand name drugs in this country. So it fits with kind of some narratives that are out there. We have been seeing a lot of states passing legislation that will allow for that, a lot more are considering it. And of course, the administration has put forward a rule that would create a process for importation to take place. Still kind of in the early stages, but this is definitely an idea that has gotten a lot more attention lately. Next slide. Another kind of approach to the idea of helping people with their prescription drug costs and access is looking at formularies. There are some plans that have made changes in the middle of the year that make it where the enrollee in the plan no longer really is getting the coverage that they need. So they make a plan decision on the basis of a formulary saying my drugs are covered, they're covered in a way that is affordable and accessible to me, and then there's a change and it makes the plan kind of no longer a good fit. So there's a kind of a spectrum of changes out there. Some of them are allowing plans to make some changes, but only if they're positive changes. There are also some approaches that go a little bit too far in terms of restrictions, because they might freeze the formulary indefinitely. And that, unfortunately, really ties the hands of plans and can lead to higher costs and prices down the road. So there's a balancing act there in the sense of protecting consumers, but then not going so far that you unfortunately give a lot more power to drug manufacturers and can actually run counter to what it is that you're trying to do. Next slide. Going back to the theme of cost sharing, this is an issue that has gotten a great deal of attention at the state and the federal level. There's a lot of interest in this idea, especially for insulin. That is definitely a therapeutic drug or therapeutic category that has gotten a lot of attention because there are frankly a lot of diabetics in this country, and also insulin and insulin prices really are the poster child for bad behavior. You are talking about a product that's been around for almost 100 years. And we've been seeing some incredible price increases over the past decade with no real way to justify those price increases. And unfortunately, that has led to a lot of people being unable to afford a product that they need to stay alive. So insulin has definitely been a topic of interest. The idea of a cost sharing cap is understandably incredibly popular with patients. However, as I mentioned previously, this is a solution that is a little bit of a stopgap in the sense that, yes, you may limit right now, but you're effectively squeezing a balloon. And if you don't bring down the prices of the products that are being covered, that will ultimately lead to higher premiums and higher cost sharing. Another thing to keep in mind is that while helpful, cost sharing caps also effectively shield drug companies from the consequences of their bad behavior and could ultimately lead them and encourage them to engage in more bad behavior. They're not really going to have an incentive to do anything about their pricing behaviors unless there are some consequences for it and they hear from consumers. And unfortunately, as helpful as cost sharing caps are, they do serve as kind of a buffer that drug manufacturers can and will take advantage of. Next slide. And of course, I'd be remiss if I did not mention what ideas are out there coming from drug companies too. The first I mentioned previously, which is rebates. A second is value-based purchasing, which I think was touched on earlier. AARP is very supportive of the idea behind value-based purchasing, but we're also very cognizant that this is very early in development and will not result in a meaningful change in pricing anytime in the near future. And it's because of some very fundamental issues. One is there is no definition of value. I think if I asked everyone on this call how to define value, I would get a different response from everyone. And something else to keep in mind is this type of purchasing has really only been available for a few drugs at this point, and there are a lot of prescription drugs on the market. So while a very important and definitely a direction that we want to be heading, it's a long-term solution. And I think we need to be clear about that. Another solution that I've been hearing a lot about lately is expanding the use of biosimilars, which are kind of the generic versions of biologics that I mentioned previously. First of all, I find that kind of fascinating because as someone who's been working in this space for a while now, when biosimilars were first entering the market, drug companies did everything in their power to keep them from getting on the market, and suddenly now they've become a solution. But either way, expanding the use of biosimilar drugs is definitely something that's been pushed. And then, of course, they've also been extremely effective in blaming everyone else, which is something we've been seeing with the pharmacy benefit managers and many others. So again, they have some ideas too, not necessarily ones we agree with, but there are definitely ideas out there too. Next slide, please. So an idea, like we've obviously got a lot of ideas, but there are some questions as to, okay, so why aren't we doing something? We've got consumer support, we've got political support, what's happening? So next slide, please. I think the most important thing to keep in mind is that our system is remarkably complicated. We have given drug manufacturers a lot of power. There is a reason that the phrase, what the market will bear, exists. Unfortunately, that is how we see a lot of our prescription drugs priced in this country, and what we're seeing is the consequences of that. We also have a remarkably fragmented healthcare system. It's very difficult for one part of the system to make some headway, knowing that drug manufacturers, frankly, are free to increase prices for other parts of the healthcare system. And that goes back to kind of that squeezing of the balloon. As long as drug manufacturers are free to price in the way that they are currently pricing their products, which means, okay, that's fine, we might reduce our prices somewhat here, we'll just make these other people pay more, that is a problem because it's very difficult to get kind of a groundswell of support unless at this point it's something that affects absolutely everyone and you're able to negotiate those lower prices for everyone. Because otherwise there is a risk that someone will say, well, what about me? Understandably, because we've given manufacturers so much power. And then something else to keep in mind is the Food and Drug Administration really is not focusing on price. They're focused on safety and efficacy. And they also are not focusing on comparing drugs. There are other countries that will take a look at a new drug and say, okay, how does this compare to an existing drug? And does this represent a meaningful improvement? And use that to kind of think through how they're pricing those products. We don't do that. So we have products entering the market that may in fact be worse than products that are already out there. And we're still giving them that premium price. So that's another challenge, is that we just don't make those hard assessments, I think, that we see in other places. Next slide. Of course, I would be remiss if I did not mention this. The drug manufacturers are incredibly effective at their jobs. As I mentioned previously, they're very good at diverting attention. So it's the pharmacy benefit managers, the insurers, the hospitals. There has been a very long list of, other entities that are responsible for what consumers are experiencing, anything other than saying it's the high prescription prices that we are setting. Another thing that's really important to keep in mind is that they have a lot of funds, and it can make it very difficult to figure out the motivation behind positioning for certain entities. So an example that's been getting a lot of attention lately is the patient groups, who may see a lot of funding from industry, and that may drive their positioning in ways that maybe differentiate them from other groups that represent patients or consumers. So it's very difficult sometimes to figure out what's driving, but a lot of times you will see some groups, frankly, parroting talking points that come from the drug industry. So it's important to kind of keep an open mind in terms of exactly where they are coming from. And then, of course, messaging from the drug industry is incredibly effective. There is a reason that they use it. One of them I like to refer to as it'd be a real shame if we didn't cure Alzheimer's. I'm sure there are plenty of people that have heard that in response to efforts to try to bring down prescription drug prices. And that's effectively saying, if you don't give us everything that we want, we aren't going to cure the things that are important to you. And of course, and understandably, that messaging is incredibly effective with both consumers and policymakers, because they do want to see that innovation. They do want to see drug manufacturers do what they theoretically are here to do. So that type of messaging can be a real problem and a real barrier to making any progress. Next slide, please. So what do we see in the future? Next slide. You can see from this picture a cracked crystal ball. That is the one thing that I've been hearing from pretty much everyone in this space lately, is that everything has been thrown out the window and we have no idea what's coming. But I think there are some very broad themes and ideas that we can take some comfort in the fact that they will occur. One is that, unfortunately, we really are in a position where we are just waiting for the next source of outrage. What drug will be coming on the market with a high price? What drug manufacturer will increase their price excessively? The one thing we can say with a great deal of surety is that it will happen at some point. We are in a unique time in that right now drug manufacturers are getting a little bit of a white knight syndrome, understandably, in the sense that everyone really is relying on them to come up with treatments for COVID-19. I think the challenge for them and for us will be whether those products will come on the market with prices that make those products accessible and affordable to everyone. If drug companies do not provide their products for this pandemic at prices that make drugs affordable and accessible, it's hard to overstate exactly how much they will effectively ruin any sort of kind of improvement in their reputation that they've received over the past several months. I think that something else that's really important to keep in mind is that all of the problems that I highlighted earlier in this presentation will be bigger after the current pandemic crisis slows. We're seeing a lot of people who are losing their jobs. We're seeing a lot of people who are losing their coverage. And unfortunately, those same people are the ones who are struggling to pay for prescription drug prices when they had coverage and when they had jobs. So I do foresee this becoming an even bigger problem in the future, because we are going to be dealing with some financial crises that will frankly make it even more difficult for people to afford their prescription drugs. So I do not see this as an issue that is going anywhere anytime soon. Next slide, please. So in terms of what's needed, it's hard to overstate how big of a strategy is needed. This is definitely a long-term issue. There are a lot of different ways that, or a lot of different challenges that need to be addressed in order to help bring down prescription drug prices. I think the important thing to keep in mind is that this is, as I mentioned, there's a squeezing of a balloon situation. So you really do want to have as many stakeholders in the room as possible in order to kind of discuss and agree on the proposed solutions. And something else that's kind of unique in this space is that prescription drug prices, the market is, there's a lot of money floating around in that market. And it can be challenging because there are a lot of different entities that are benefiting from the money that's floating around in that market. And so the example I like to provide is allowing Medicare Part D to negotiate on prescription drug prices, which has a great deal of support. However, it has been a challenge to try to follow that particular approach because it has created kind of a strange bedfellows in the sense that, one, drug manufacturers do not want the government involved in negotiating on prices, but two, Medicare Part D plans and PBMs play a very big role in the Medicare Part D market, and they want to continue playing that role in the Medicare Part D market. So there is a lot of strange bedfellows that can be created in trying to address prescription drug pricing, and that's something else to be mindful of. Next slide, please. So what if nothing changes? Hopefully, I've been able to make it clear that this really is an issue that must be addressed. What we are seeing now in prescription drug pricing and costs simply is not sustainable. It's also important to keep in mind that this is not an issue that you can address indirectly. You cannot tell consumers that you have reduced prescription drug prices because they will invariably go to the pharmacy and find out for themselves. So you really do want to come up with solutions that consumers actually feel the impact of ultimately down the line. It's also important to keep in mind that this is billions of dollars at stake. You're looking at taxpayer-funded programs, you're looking at savings for taxpayers. So Medicare and Medicaid, we're looking at billions and billions of dollars from prescription drugs. Especially given the current budgetary environment, I would hope that is incredibly appealing in trying to find ways to bring those prices down. And then, of course, the one point that really matters most to AARP and its members is that this issue, if it is not addressed, we're going to see more and more people who cannot afford their prescription drugs. And that ultimately will lead to higher healthcare costs down the road. And it really is something that we need to be mindful of, is this issue is not going away, and unfortunately, it is getting worse. And then finally, I think one thing I always like to point out, because the innovation argument has certainly been used to great effect, is that even if drug companies are the most innovative companies in the world, the reality is that innovation is meaningless if no one can afford to use it. Next slide, please. Thank you very much, and I'm happy to take your questions.
All right, thank you, Lee. Really appreciate that presentation, appreciate all the information you shared, and thank you for your ongoing efforts to address this issue. We do have time for probably a question or two. Does anyone have any questions for Lee? Peter, yes, go ahead.
Hi, Lee. This is Peter Photos from Pharma. Thanks for all that. Appreciate it. I'm being serious, honestly. But with all the data that you gather, are you only looking at the list prices, or are you actually taking into account rebates and discounts, which bring you down to the net price?
Well, to the extent that we can, we do use retail prices for our price tracking. But as you well know, rebates and discounts kind of hard to come by. So our offer has always been, if someone would like to share that information with us, we would be happy to use that in our analysis. But we are using the best that we can, which is those negotiated prices.
Has AARP ever asked United Healthcare to share that data?
Oh, no. There is a very strict and strong firewall, so we would never make that request.
Okay. And just to kind of respond to a couple things you just said, and it's, I don't want to nitpick, but when you were talking about the rebate rule and how none of our CEOs, when they were before the Senate Finance Committee last year, would commit to anything. In fact, all of them said that list prices would come down if rebates were done away with. It's hard to commit to something in a vacuum when you don't know what that looks like, but they all agreed that that list prices would come down if rebates were done away with. So that's just,
they did agree that they would come down. Sorry, go ahead.
No, go ahead. No, finish.
I was just going to say they agreed that they would come down, but they did not agree to fully encompass that delta, and they did not say that they would come down to net.
Well, like I said, I mean, it's recognizing the reality of the situation, the system that we currently work in. So you can't really answer questions like that in a vacuum with you know, yeah, we're going to do it right now. But, you know, in the abstract, when you talk about getting rid of rebates, they all agreed that list of prices would come down. The other thing too, you talked about cost sharing. You know, when we bring up cost sharing as an issue, that's because I'd just like to make a comment. That's because whenever we engage in negotiation with plans and PBMs, it doesn't matter what type of plans they're negotiating the drugs for. It's a straight up discount. So when people who are in high deductible healthcare plans spending, you know, $5,000 to $10,000 before their actual insurance kicks in, the discount exists. It's the plan that's not giving them that discount because they have to hit that deductible. When we've always argued that you're getting the plans and the PBMs are negotiating the discounts, so why not give them to the patient no matter what, regardless what plan they're in? So I'm a little confused by that one. And then finally, when you talk about that we just blame everybody else, we've heard multiple studies, one from Dr. Sood from the University of Southern California earlier back in January, that almost 50% of the list price is lost somewhere in the supply chain. And I don't think it's finger pointing to say that and to want to know where that, you know, 48% of the list price is going in the supply chain and how it's being used and who it's being distributed to. So I just took a little issue with that, but I'll leave it there.
All right, thanks, Peter.
I'm happy to respond. Go ahead.
Yeah, I was just going to say.
If it was a comment, it's a comment.
Yep, if you wanted to respond to that at all, that's fine. If not.
No, I think I was clear that there is certainly a lot of excess in the system, and there are a lot of different ways to address it. I think our position has always been that the price is what starts that entire chain, and that is where we need to address the price first. The manufacturers are responsible for setting the prices, so that's where we are focusing our efforts.
Yeah, we're responsible for setting the prices, but we're not responsible for what the patient actually pays at the pharmacy counter.
Okay, thanks, Peter. Doesn't look like there's any additional questions at this time. So again, Lee, thank you very much. Really appreciate you taking the time to be here and providing this information.
Absolutely, thank you for having me.
That's good. So I know we do have a 10-minute break scheduled, but I think since we're just a couple minutes behind schedule, and in order to make sure we do have time for the full presentations with discussion for the last two, I think we'll just power through. And Gary, if you're ready, I will turn it over to you, Gary from the American Diabetes Association.
I am ready, and
fantastic. Well, thank you. We got your slides all loaded, so the floor is all yours.
Okay. Thank you. My name is Gary Daugherty. I am the Director of State Government Affairs for the American Diabetes Association. And I do appreciate the opportunity to discuss ADA's activity in the insulin affordability space, share some consumer perspectives, and highlight some policy recommendations with the task force today. Megan, can we advance to the next slide, please? Thank you. We at the American Diabetes Association consistently hear from people with diabetes who struggle to afford their insulin. And there's no medication that can be substituted for insulin. It is, in fact, life-sustaining, and many Wisconsinites are struggling to obtain the insulin they need to survive. Next slide, please. J.H. from Eau Claire has told us, I watched my parents struggle to afford the insulin my father needed to stay alive. The cost shouldn't impact someone's ability to maintain an acceptable quality of life. And DWR from Fitchburg has said, I've lost my job twice in recent years. Both times I lost my health insurance. The first time I had to go door to door with different doctors asking for insulin samples. My husband and I had to ask really difficult questions like, Do we sell the house? Do we skip meals to spend less on groceries? Next, please.
See what I look like. And then
ML from Milwaukee shares a common frustration. The cost of insulin is a real big part of my budget and is a hardship for me to afford on a limited income. This is legal robbery, what the big pharmacy companies are doing to us. And RL from Oak Creek says, I just recently moved out on my own and often have had to choose between getting my insulin I need to survive and eating dinner. I shouldn't have to choose between staying alive and treating my incurable illness. These, as well as the family we saw on the opening video a couple of hours ago, are the voices of Wisconsinites who are struggling on a daily basis to afford their life-saving insulin. Next, please. More than 34 million Americans have diabetes, and nearly 7 million of them rely on insulin to manage their disease. Many people with diabetes need insulin to live and to avoid devastating complications that include blindness, kidney failure, lower limb amputations, heart attack, stroke, and even death. The high cost of insulin puts this life-saving drug out of reach for many who need it. In fact, the average price of insulin has nearly tripled between 2002 and 2013 and has doubled since then for a medicine that's nearly 100 years old. There have been incredible advances in research and development and technology that have improved the lifespan and quality of life for those who have diabetes. But the formula for insulin has not changed significantly since the 1990s. Next, please. So how does insulin pricing affect people living with diabetes in Wisconsin? First, let's get a basic understanding of the numbers that illustrate the state's diabetes epidemic. Next, please. According to ADA research, 439,000 people in Wisconsin, or about 10% of the adult population, have diabetes. Next, please. An estimated 135,000 more have diabetes but don't know it, greatly increasing their health risk. Next, please. In addition, another 1,560,000 Wisconsinites, more than a third of the adult population, have prediabetes, with blood glucose levels higher than normal, but not yet high enough to be diagnosed as diabetes. Unless they adhere to a plan to get their blood glucose levels under control, including an improved diet and exercise plan, they're at risk for developing diabetes. Next, please. Every year, back one, please. Every year, an estimated 34,000 people are newly diagnosed with diabetes in Wisconsin. And then next, please. Diabetes is expensive. People with diabetes have medical expenses approximately 2.3 times higher than those who do not have diabetes. Next. Total direct medical expenses for diagnosed diabetes in Wisconsin were estimated at $4.1 billion in 2017. Next. And another $1.4 billion was spent on indirect costs from lost productivity due to diabetes. Next, please. Approximately 5 to 10% of people with diabetes have type 1, which means their pancreas doesn't make insulin at all, or makes very little insulin. So it has to come from an outside source. So in Wisconsin, based on ADA statistics, somewhere between 22,000 and 44,000 people have diagnosed type 1 diabetes and require insulin to live. Some people with type 2 diabetes also require insulin drugs, as over time, their natural insulin production becomes less adequate. Although I've seen some estimates of about a quarter of those with type 2 diabetes require insulin, I've not seen any recent data, but if that figure is generally accurate, another 100,000 or so Wisconsinites also require insulin. Next, please. As the nation's leading voluntary health organization fighting to bend the curve on the diabetes epidemic, the American Diabetes Association's mission is to prevent and cure diabetes and to improve the lives of all people affected by diabetes. As such, we believe that no individual in need of insulin should ever go without it due to prohibitive costs. Next, please. The American Diabetes Association has been and continues to be a leader in the insulin affordability discussion. In 2016, ADA's Board of Directors passed a resolution that first called upon all entities in the insulin supply chain, so that's manufacturers, wholesalers, pharmacy benefit managers, insurers, and pharmacies, to substantially increase transparency in pricing associated with the delivery of insulin to the end user patient. Secondly, the resolution also called upon all entities in the insulin supply chain to ensure that no person with diabetes is denied affordable access to insulin. And finally, the resolution called upon Congress to hold hearings with the entities in the supply chain to identify the reasons for the dramatic increases in insulin prices and to take action to ensure that all people who use insulin have affordable access to the insulin they need. Next, please. At the same time the ADA Board of Directors adopted the resolution, the association launched a grassroots petition, which to date has received more than 523,000 signatures from folks across the country who want to see action on the issue of insulin affordability. Next, please. The Insulin Access and Affordability Working Group was formed in early 2017. The working group was charged with determining the full scope of the insulin affordability problem and to help determine viable long-term solutions that will reduce the out-of-pocket costs of insulin for individuals with diabetes. Throughout 2017 and early 2018, the working group met with stakeholders from across the supply chain, as well as with people living with and affected by diabetes. The meetings were invaluable in helping the association learn more about the complex supply chain and each stakeholder's role. Next, please. Some of the conclusions reached by the working group were presented in a white paper that was published in the journal Diabetes Care. Among the conclusions were the current pricing and rebate system encourages high list prices. There is a lack of transparency throughout the insulin supply chain. People with diabetes are financially harmed by high list prices and high out-of-pocket costs. Patient medical care can be adversely affected by formulary decisions. And the regulatory framework for development and approval of biosimilar insulins is burdensome for manufacturers. The white paper, including the full list of the working group's conclusions and recommendations, can be accessed at the link shown on this slide. Next, please. Following the publication of the white paper, ADA released a public policy statement improving insulin access and affordability. Key recommendations included increasing pricing transparency throughout the insulin supply chain, lowering or removing patient cost sharing for insulin, streamlining the biosimilar approval process, and increasing access to healthcare coverage for all people with diabetes. And again, this public policy statement is available at the link shown at the bottom of this slide. Next, please. You'll recall that one of the requests within the ADA board resolution was for Congress to hold hearings on the issue of insulin affordability. Congress responded by holding at least a dozen hearings. ADA played a critical role in providing testimony at many of these hearings, and we will continue to urge Congress to hold hearings and, more importantly, to take action on this vital issue. Among the hearings in which ADA played a role were before the U.S. Senate Special Committee on Aging. Dr. William Cefalu, ADA's former Chief Scientific Medical and Mission Officer, testified before the committee. On the same day, the working group's white paper was published online in Diabetes Care. ADA also played a prominent role in a hearing conducted by the U.S. Senate Finance Committee. This hearing featured an ADA advocate from Indiana who presented compelling and frankly heartbreaking testimony about how her son began rationing his insulin when he found out the cost of it and was trying to help his family. As it turns out, he put his own health in danger. Next, please. During ADA's testimony before Congress, this representation of the complexities of the insulin supply chain was shared. There are numerous stakeholders involved in the delivery of insulin, with multiple rather opaque transactions between and among each of the stakeholders. In order to better understand the role of each link in the supply chain, there must be full transparency. Because all of the entities in the supply chain, from the drug manufacturers to the wholesalers, to the PBMs, to the health plans, to pharmacies, aren't voluntarily explaining how their pricing works so that we can tell why costs have gone up. We're ready to work with legislators to require the information needed to answer the questions. Next, please. So how much does a vial of insulin cost? Next. Most commonly prescribed insulins typically cost upwards of $300 per vial without insurance, and people often need multiple vials of insulin each month. Next slide, please. And how much does it cost to manufacture a vial of insulin? Next, please. A study published by BMJ Global Health estimated the cost of production for a vial of most analog insulins, those are the newer, more effective insulins, is between $3.69 and $6.16. Examples of analog insulins include Humalog, which is made by Eli Lilly, Lantus by Sanofi, and Novolog by Novo Nordisk. Next, please. So why is the cost of insulin so high? Next. According to ADA's Insulin Access and Affordability Working Group, a number of variables contribute to the high cost of insulin. The first of which is a lack of transparency throughout the insulin supply chain. It is unclear precisely how the dollars flow and how much each intermediary in the supply chain profits. This lack of transparency clouds the true cause of higher prices. Next, please. Additionally, the current pricing and rebate system encourages high list prices. As list prices increase, the profits of the intermediaries in the insulin supply chain increase, since each may receive a rebate, a discount, or fee calculated as a percentage of the list price. Next. Finally, with only 3 major manufacturers of insulin, there's just no real competition. Next, please. To reinforce the obvious, insulin is not a choice. Scaling back on insulin can lead to costly and sometimes deadly complications. As part of our ongoing study of the insulin affordability issue, the American Diabetes Association explored perceptions and behaviors related to insulin affordability among insulin users in the United States. Roughly a quarter, about 27% of respondents to the nationally representative survey indicated that cost has affected their past year purchase or use of insulin. Behaviors resulting from the impact of cost on insulin purchase included taking less insulin, missing doses, using a less expensive prescription, and not filling prescriptions. Using less than the prescribed amount of insulin can result in uncontrolled glucose levels in the blood, which can lead to damage to one's eyes, kidneys, and heart. It should come as no surprise that people with diabetes with low medication cost sharing are more adherent than those with higher cost sharing. Research supports this by showing that an increase in monthly cost sharing of just $10 or more for people with diabetes is associated with a decrease in medication adherence of about 18%. Ultimately, without enough insulin, diabetic ketoacidosis can occur. If untreated, it can lead to a diabetic coma or even death. Next, please. The ADA has also launched a website, insulinhelp.org, to help connect people who use insulin with the resources they need. Insulinhelp.org contains information and instructions to contact insulin manufacturers who may be able to offer immediate assistance for those who are struggling with their insulin costs. In addition, it contains links to local community health clinics or pharmacies that may offer access to free insulin or require a very small fee. Whereas patient assistance programs may be helpful for some, the ADA does not view them as a long-term solution to the challenges of insulin affordability for a number of reasons. There are limits to who is eligible for many assistance programs. Many programs operate outside of health insurance. Many programs have time and/or quantity limits and can be ended at the discretion of the manufacturer. The application process for assistance programs can be onerous and must be completed at least annually. And most programs require application and approval before the individual receives the medication. Next, please. Notwithstanding the congressional hearings that have been held, the introduction of bipartisan legislation such as the Insulin Price Reduction Act, states are simply not waiting for the federal government to act. Next, please. The American Diabetes Association has joined with other diabetes stakeholders to support legislation to cap the amount a patient with diabetes pays each month for their insulin. This would apply to all state-regulated commercial health insurance plans. In May of last year, Colorado became the first state in the nation to enact an insulin copay cap bill. The law has two prongs. It caps copays for insulin at $100 per month, regardless of the type of insulin or the number of vials a patient might need. And it calls on the Colorado Attorney General to investigate the rising prices of insulin in the state and make recommendations to the General Assembly for further action. Soon after Governor Polis signed the bill in Colorado, other states' legislators began exploring the possibility of replicating the bill in their own states. Next, please. Insulin copay cap laws have now been enacted this year in Illinois, New Mexico, Maine, West Virginia, Utah, Washington, New York, and Virginia. And just last Thursday, New Hampshire became the 10th state to do so when Governor Chris Sununu signed that state's copay cap into law. It is a $30 cap per prescription. And I just learned this morning that Delaware Governor John Carney has signed a $100 per month cap into law. So there are now 11 states. Progress is being made in a number of other states as well. Next, please. Here in Wisconsin, Senator Dave Hansen and Representative Jimmy Anderson introduced Senate Bill 340 and Assembly Bill 411, respectively, last fall. Similar to the Colorado bill, each bill sought to establish a monthly copay cap on insulin and require the Commissioner of Insurance to investigate and report on the pricing of insulin. The Wisconsin bill was just a little bit different. Rather than just a straight $100 cap, the legislation would prevent health plans from imposing cost sharing in an amount that exceeds the lesser of $100 or a more complex rebate-based calculation. I'm not really sure of the rationale or the logic behind the complex calculation, but since the bill says that the cost sharing should be the lesser of the two options, the ADA supported this legislation as it was in line with our priorities. By keeping insulin affordable, we can help people with diabetes, help keep people with diabetes out of the ER, out of the hospital, and away from expensive and potentially disabling or deadly complications. Unfortunately, neither bill gained sufficient traction during the session. And although Senator Hansen is not seeking re-election, ADA will continue to work with the legislature to enact an insulin copay cap bill next session. Next, please. So anticipating some questions you might have, we are commonly asked, if we set a copay on insulin, are we going to be asked by patients of other diseases to set a cap on those copays as well? I can only respond to the value of insulin, which is a chronic disease maintenance drug that is necessary for people with type 1 diabetes and many with type 2 to live. Insulin has also seen dramatic price increases, as we have seen in previous presentations, in a relatively short period of time. So as I've mentioned, if insulin is unaffordable, people are more likely to ration or otherwise become less adherent to their medication regimen. When that happens, the risk of hospitalization for complications can increase and the cost can be substantial. I recently learned from the Wisconsin Division of Public Health that last year, there were 6,342 hospitalizations where diabetes was the principal diagnosis, with the median charge being $31,181. We would expect copay cap laws to help reduce hospitalization costs. Next, please. Also, won't the copay cap result in an increase in premiums? In Colorado, the first state to enact an insulin copay cap law, a review of regulatory filings from insurance companies doing business in the state found that most plans didn't even mention the insulin caps at all as being a factor in their calculations. And when they did, they used terms like negligible or de minimis. Likewise, in Washington, the state of Washington, which enacted a cap on insulin copays at $100 a month, 15 health insurers filed an average proposed rate decrease of 1.79% for the 2021 individual health insurance market. Fiscal analyses were also conducted in other states where similar legislation is being or has been considered. An analysis of similar legislation under consideration in California determined that any potential premium increase would be less than 1%. And in Kentucky, a fiscal note indicated that a potential, any potential premium increase would be as little as 7 to 24 cents per person per month. Next, please. The American Diabetes Association supports efforts at the state and federal levels of government to ensure access to adequate and affordable health care, including making insulin affordable and accessible for all who need it. Among the legislative recommendations ADA endorses are to ensure access to adequate and affordable health insurance, and this would include Medicaid expansion. Wisconsin is now one of 13 states not to have expanded Medicaid. With the recent voter approval in Oklahoma and the upcoming statewide vote in Missouri, we are hopeful for momentum to build, leading the Wisconsin legislature to see the value of extending medical coverage to more than 176,000 Wisconsinites. Requiring transparency throughout the insulin supply chain. Our recommendation would require entities in the supply chain to report certain pricing, sales, and profit data to a designated state agency. It would apply to insulin manufacturers, pharmacy benefit managers, pharmacies, and health plans doing business in the state. Information submitted to the agency would be compiled in an aggregated report and provided to the state legislature and insurance commissioner's office. And finally, we would like to see that report published on the agency's website as well. A third recommendation is to lower or remove patient cost sharing for insulin. Examples of this would include capping copays for insulin, regardless of the type of insulin or the number of vials needed. Although Colorado, Illinois, West Virginia, Washington, New York, and now Delaware cap their copay at $100 per month, there's no real magic to that particular figure. The New Mexico cap is $25. It's $30 in Utah and New Hampshire, $35 in Maine, and Virginia capped their insulin copay at $50 a month. Another example would be to exempt insulin from the deductible. Next, please. The ADA also recommends that the value of copay assistance programs be applied toward a patient's deductible. This is very similar to Senator Jacques' Senate Bill 907 that was introduced at the end of this past session. This type of legislation is generally in response to individuals using copay coupons to help pay for expensive medications that their provider has decided to be the best course of treatment. Coupons distributed by the manufacturer are necessary for some patients to purchase life-saving medications. Therefore, payments made toward these medications through coupons or other copay assistance programs should be counted toward the patient's cost-sharing expenses. Next, please. In conclusion, our everyday reality is that more than 35 million Americans have diabetes. Nearly 7 million of them rely on insulin to manage their disease. The average price of insulin has tripled between 2002 and 2013, and 1 in 4 are using less insulin than prescribed due to the high cost. It's time to reduce the financial burden on the state and on Wisconsin diabetes patients who need insulin. The American Diabetes Association believes that no individual in need of life-saving medications should ever go without due to prohibitive costs or accessibility issues. Next. I appreciate the opportunity to join you today. The American Diabetes Association stands ready to work with you, your colleagues, other stakeholders to address the high cost of insulin, and I'll do my best to answer any questions that you might have. Thank you.
Sounds good. Thank you, Gary. Really appreciate that presentation. Appreciate you spending a lot of time talking about insulin affordability. That's something that we've been hearing a lot about, especially from the consumer stories that we've been hearing throughout our meetings. So really appreciate that. We do have time for some questions. So Janet, it looks like you have a question. So go ahead.
Thank you, and thank you for your information on diabetes. I have a question on the insulin cap, copay cap. Is there any evidence, any information yet to say how effective that is? If it has decreased ER visits, or is it just too early to tell?
It's a very good question, and it's one we're eager to get the answer to as well. This is still a relatively new concept. Colorado's law was passed last May, I believe, and just went into effect at the beginning of this year. So there's not a lot of history yet to learn from. So unfortunately, I can't answer your question. I think that our belief is that it will, based on the research that we've seen and some of which I've shared with you. But I don't have any direct results from the copay cap laws.
Thank you very much.
Sure.
Okay, Dr. Goldrosen, go ahead.
Yeah, I had two questions. First to Gary. If there's a cap on insulin, whether it's $30 or $100 or whatnot a month, is that to cover all insulins, or is it to cover, per product? So if you're on a long-acting insulin and a short-acting insulin, is that covered under the $100 per month, or is that $200 per month?
Another good question, and it really depends on the law, depends on how it's written. In some states, it is a collective cap, so it's whatever the cap is. Let's use $100 for an example. It would be $100 regardless of how many insulin prescriptions you might have, long-acting, short-acting, and so forth. In other states, it is per prescription. So if you have 2 prescriptions, then using $100 as an example, then the tab would be $200 per month. Obviously, our hope is to decrease the amount of cost sharing for our patients, but we don't write the law. We can advocate, but we don't write or vote on the laws.
So a second question for Gary, or for any of the pharmacists or anybody else on the line. I think the first analog insulin, probably the Lispro short-acting or the Glargine Lantus long-acting, probably came out around 23 years ago or something like that. So we have some other brand name products that have come along in the last 5 to 7 years, and I think that probably has caused a little bit more price competition, a little bit. But why 23 or so years later do we not have any generic products?
I don't know the exact answer to that question. I think it is because, I think part of it is because of the makeup of the product, that it's not a true generic. It would be a biosimilar, and that's kind of a complicated comparison, but there might be a couple other folks on the call who might be able to shed a little more light into that.
Peter, did you want to chime in there?
Yeah, Dr. Goldrosen, I'll do my best, at least from our perspective, and it's not going to be a complete answer, so I apologize in advance. Take Humalog, for example. That technically it's not on patent, so it's not a generic, but it's not on patent, so it's kind of in that limbo. And during our presentation yesterday, there were some questions about why one company doesn't get into the insulin space to create competition. Usually it's because startup cost is prohibitive for a company, especially a company that isn't historically in that space, to actually get in there and do it. So there's just not a lot of expertise, at least in the industry, outside of the 3 primary manufacturers to do it, even though one of those products is technically not on patent anymore and could be manufactured by anyone at this point, if they have the startup money to do it. So I know that's an incomplete answer, and I'm sorry I can't give a better one, but that's kind of how we see it right now.
Thank you.
Okay. Josh, you had a question?
Yeah, Gary, there was a slide you had that the cost to make a vial of insulin was like $3 to $6. I was not familiar with that study. Is there any effort going on? I know it couldn't be done at the state level, but maybe the federal level, to limit the price of insulin overall. And I understand the concept of limiting a copay. Essentially, that's pitting other disease classes against each other. You know, small increase in planned costs, I get that. But what about the overall issue of the price of insulin?
We certainly support, obviously, the overall decrease in the price of insulin. I'm not necessarily privy to all the conversations that are going on at the federal level. I would say, I know that there have been discussions, but I think it all kind of comes back to transparency, and it's really difficult to see, to know and understand how these prices are arrived at, because there are so many people in the supply chain, each have a different stake, and it's pretty opaque, as I mentioned earlier. So I think until the transparency is unraveled a bit in this, we're not going to really know what where we can lower the cost of insulin, get the overall cost down. I know that's probably not a perfect answer, but I don't know that there is a perfect answer right now.
Yeah, and I don't know that they're fair comparisons, but I mean, we've seen numbers of, you know, the net cost is $55. I've seen other ones where they're talking 100 or 200. So if we remove all the transparency, if we get, or not remove, but if we take away the items that people are saying, you know, this is making it less transparent, we get to that net price, it seems like that's still a heck of a lot more than $3 to $6.
Mm-hmm. Yeah, I can't comment any further on that, but I understand the concern.
Okay, thanks.
Okay. Yeah, it looks like Yolanda had a question in the chat box regarding off-patent manufacturing of insulin by groups like Civica. Peter, did you want to respond to that?
Oh, I'm sorry, I don't have an answer for that. I was just going to comment on the last question. Yeah, I don't know much about Civica and how they do their stuff, so I wouldn't feel comfortable commenting on that.
Okay. So does anyone have any comments on Yolanda's question? No. Okay, well, Yolanda, maybe we can follow up with Civica and see if we can get a response from them about that. Peter, go ahead.
Well, I was just going to say about the comment about the cost of manufacturing, Gary. I understand why you put that in there. Once you've got a drug developed, the cost of manufacturing is not what makes it prohibitive. It's the overall R&D costs over the long term. You know, not all insulins anymore are created equal. There's different delivery systems or different timing on how they're released into the body, and you know all this. I'm not gonna go into it, but I know we've heard from a couple other presentations. I think maybe PCMA, maybe AHIP. I can't remember. We talked about, you know, pennies on the dollar to manufacture. Well, yeah, it's cheap to actually manufacture once you have everything in place. FDA has approved your facility for manufacturing. That's when that process is relatively cheap. But I just wanted to make sure everybody kind of understood the difference between the cost of manufacturing and the cost of development.
And I think that's a fair point to make. I think that's part of the quest for transparency, is understanding what those R&D costs are, how they factor into the pricing, and to my knowledge, we don't really have access to that, but I understand that.
Okay, doesn't look like we have any more questions at this point. So again, Gary, thank you. Really appreciate the presentation, and thanks for sticking around for some Q&A.
Thank you. Let me know how I can be of further help.
Sounds good. Okay, so we're still on schedule, and we're getting to our last presentation here. So I will turn it over to Bill and Peggy from Vivint Health, formerly known as the AIDS Resource Center of Wisconsin. So Bill and Peggy, it's all yours.
Great, thanks Nathan. Appreciate the opportunity to be here today. I kind of have a two-part presentation. I'll be talking about the experience of Vivint Health here in Wisconsin as a provider of integrated care to people living with HIV, and how the 340B drug pricing program has expanded access to care for the people that we serve here in the state. And then Peggy's going to talk a little bit about some of the challenges that are applicable here as it relates to the scrutiny and some of the attacks on that program as well as some other practices that are existing in this space that are challenging not just Vivint Health as an HIV care and treatment provider, but other folks that are, or other providers that are working in the healthcare safety net. I am trying to control the screen, but it's not letting me. So I don't know if maybe that is me. All right. Just to give folks a quick overview of what we're going to be discussing today, just want to give a quick update on the status of HIV in Wisconsin, let you know a little bit more precisely about who we are and who we serve, what our outcomes are, and how the 340B program helps us. So status of HIV in Wisconsin. Today, there are about 9,000 people living with HIV. Roughly 17 to 18% of them are undiagnosed, meaning they're living with HIV but have not yet been tested, and are unfortunately folks that are well positioned, unfortunately, to transmit HIV to new individuals. Today, HIV infections are down from historic highs, down to about 225 to 230 diagnosed new infections in the state every year. HIV continues to disproportionately impact communities of color in the state. People of color represent about 16% of the state's population, but account for about 66% of new cases. Most of those new cases are occurring within young men who have sex with men, young gay men of color. For folks who are not from communities of color, other primary transmission modes are injection drug use, which is of course something that, given the resurgence of the opioid epidemic in our state, is something that we're certainly very well aware of. But then also high-risk heterosexual individuals, those would be individuals who are having sex with either injection drug users or men who are having sex with other men. A couple of good pieces of news here, and I think it's important to share these because it sets the tone for some of the additional work that we do. Here in Wisconsin, people with HIV live longer, healthier lives than anywhere else in the country. That's not just our data, that's backed up by the Agency for Healthcare Research and Quality, which is part of the U.S. Department of Health and Human Services as a part of their national scorecard of data. And more than 50% of people with HIV are effectively managing their HIV. This is a critically important tool, not only for managing their own health and helping to keep costs contained, but it's also an important public health goal. People with HIV who are reaching undetectable viral loads or viral suppression are physiologically unable to transmit HIV to someone else, meaning the more people we engage in care, identify with HIV, keep in care, the more likely we are to be able to achieve the goal of ending HIV as an epidemic in Wisconsin and throughout the country. A little bit about Vivint Health. We're one of the leading national HIV prevention, care, and treatment organizations. We have a unique integrated model of care called the HIV Medical Home, which integrates medical, dental, pharmacy, mental health care with comprehensive social services. We are able to provide those services to everyone at risk for HIV in the locations and the communities we serve, regardless of their ability to pay. We make sure that folks are able to access the complete breadth and depth of our services, regardless of their insurance status, regardless of their poverty levels, and regardless of their own individual ability to pay. 425 staff throughout our locations in Wisconsin, Colorado, Missouri, and Texas. $150 million a year annual budget, which is inclusive of the pharmacies that we operate and the cost of the medications that we're buying on behalf of the people we serve. Currently, we're serving about 10,000 patients and clients. Those are people all living with HIV, or a small subset of them are at risk for HIV who we're serving through prevention services. This just gives you a kind of a overview quickly of the different services that we provide. It is integrated medical, dental, mental health, and pharmacy services that are then supplanted by legal services, case management, housing, and food services, basically working to overcome all of the social determinants of health and barriers to health that our patients face on a daily basis. So who are our patients? Who do we serve? More than 90% of the people we serve are living below 200% of the federal poverty limit. This means that not only they are experiencing poverty, but are simultaneously experiencing food, shelter, and economic vulnerability. challenges with safe and affordable housing, nutritious food access. Many of our patients live in food deserts, are all contributing factors to not only their HIV status, but also this next piece, which is that more than 85% of the patients we serve have co-occurring chronic conditions or mental health diagnoses along with their HIV diagnosis. A little piece of additional interesting news here. Most people think of HIV as a disease impacting primarily young people, and it is true that most new infections are amongst young people. That said, more than 55% of our patients are over the age of 45. That means if you look at where the epidemic was 25 or 30 years ago, when unfortunately it was still a death sentence for many individuals, and we were having high death rates amongst individuals who are infected, we've been able, through the increase in access to care and increase to appropriate medications and effective medications, been able to help people live long, healthy lives. That means, unfortunately, however, we're faced with helping patients not only successfully manage their HIV, but other co-occurring conditions that are usually seen within an aging population. And as I said earlier, we provide the same level of care to all of our patients, regardless of race, ethnicity, gender identity, sexual orientation, or poverty status. I want to talk a little bit about our outcomes because I think it's an important aspect of the quality of care that we provide, regardless of an individual's ability to pay. As I indicated earlier, suppressed viral load is probably the most important clinical indicator. Not only is it best for the patient's individual health, but it also helps to reduce HIV transmission to other vulnerable individuals. 81% is the national benchmark for HIV clinics similar to ours in terms of what their goals normally are in terms of achieving viral suppression. At Vivint Health, our clinics are achieving 95% viral suppression. That's because 98% of our patients are being prescribed ARVs, antiretrovirals. These are the medications that are effective in helping patients effectively manage their HIV, but we're also helping them manage their diabetes, their hypertension, and their hyperlipidemia or high cholesterol as well. Several years ago, through a unique partnership that we have through the state Medicaid program, whereas we have a unique medical home model of care that receives some enhanced reimbursement and attention, we were a part of a study that looked at the effectiveness of our program in terms of reducing healthcare costs and improving outcomes. Really proud to report that that study at the UW Center for Health Systems Research and Analysis, or CHSRA, found that patients with HIV who are receiving their care at our clinics have a 52% lower hospitalization rate, a 48% lower unnecessary rate of use of the emergency room, and when our patients are admitted because they are sick, their hospital stays are roughly 10% shorter. Overall, this means that on an annual basis, we're saving Wisconsin taxpayers approximately $12 million a year in healthcare costs because of the high quality of care that they're receiving through our clinics. So there's been a lot of attention and focus and a conversation today around the 340B program, and just want to talk a little bit about how Vivint Health utilizes this program to provide patients and more patients with access to high quality care, great outcomes, and at lower overall cost. As I'm sure many of you are aware, the 340B program was established by Congress in 1992 as a part of the Veterans Health Care Act. And it's really important here. The intention of this program was a way to provide relief to safety net providers, clinics like Vivint Health and other similarly situated providers to combat high drug prices. And basically, in order to allow us to stretch scarce federal resources as far as possible to reach more vulnerable patients and deliver more comprehensive services. So if you think back a couple of slides, that's exactly what Vivint Health is doing in terms of its utilization of the 340B program. It's also important to know that the way that this program is structured, it has no financial impact to the taxpayers in terms of the administration of it or how the program operates. It's not a grant program. Vivint Health does not receive a grant from the federal government to participate in this program. It's administered by the Office of Pharmacy Affairs within HRSA at HHS, and there are strict eligibility reporting and compliance requirements that we are required to follow to prevent fraud and abuse within the program. we take very seriously our participation in this program and are carefully monitoring our engagement in it and making sure that we are fully compliant with the intents of the program. As many of you know, Congress federally has been paying a lot of attention to the 340B program, but there's been no significant changes in it from Congress based primarily because of overwhelming support for the program and demonstrated need for its continuation. As we said, the 340B program generates savings that us as safety net providers and as covered entities, when we buy those drugs and we have a savings that we're able to realize in this program, we are required to reinvest those savings into critically needed programs and services for our patients. We can't use those savings in ways that do not align with our mission or with the grant funding that made us eligible to participate in the program in the first place. So what do we use 340B savings to support at Vivint Health? First of all, expanding access to care, making sure that anyone, regardless of their insurance status, regardless of their ability to pay, is able to come and get the same high quality of care that anyone else would be able to do. It's also allowed us to weather what has been basically stagnant government support, government funding support in discretionary health programs for the grants that support our clinics. Oftentimes these grants have stayed level funded through the federal appropriations process, even though today there are more than 1.2 million people living with HIV across the country, and more people living with HIV who are in need of those services every year. So in Madison and Green Bay, the 340B program has allowed us to keep our dental clinics open, even though grant funding to support the opening of those clinics has stopped. It's allowed us to keep mental and behavioral health services operating in smaller communities across the country. These are unfortunately oftentimes clinics that the federal government deems maybe too small to invest in terms of the number of patients. However, we know that at least half of all people living with HIV at any given time are in need of mental health and behavioral health services. So 340B savings that we generate are invested in keeping our behavioral health services, access to psychologists and psychiatrists open throughout the year. Also, and this is important as a part of our COVID response, we've been able to double the amount of food our food pantries are able to provide to the people we serve on an annual basis. As you know, we've been sheltering in place. We've been encouraging a lot of our patients who have immune compromised situations to minimize their travel, including even coming to our clinics to pick up their medications or their food. So we've not only doubled the amount of food that we've been able to provide them, but are doing so through a home delivery model. And one of the most important aspects of 340B savings for us is using to ensure that if someone is uninsured, underinsured, uninsurable, that they're able to access their medications for free, regardless of their ability to pay. So oftentimes, people living with HIV at 200% or lower of the FPL, they don't have discretionary income to pay for medications, even after all the discounts, even if they are insured or on Medicaid, if they have co-pays or other things like that. So we use 340B savings to make sure that if someone walks into one of our pharmacies, does not have any insurance, does not qualify for a pharmaceutical assistance program, and does not have a dime in their pocket, they're still walking out of our pharmacy with all of the medications they need. And we would only be able to do that, we're only able to do that because of the 340B program. Also, as I indicated, we're using these savings to make sure that that we're able to accommodate high acuity patients who need enhanced levels of care. Oftentimes the grant funding we receive or the reimbursement revenue that we're able to generate does not fully cover the cost of the programs and services that we're offering to people. High acuity, high intensity case management services, prescription drug adherence and programs, integrating and offering services to make sure that our patients are getting all of the clinical care that they need from pharmacists embedded in our clinics. And then of course, our ability to accommodate unforeseeable funding interruptions, things like COVID-19. Really proud that we've not had to interrupt access to patient services throughout the pandemic And again, would not be able to do that without access to the savings generated through our participation in the 340B program. And that's it for my slides. I will turn it over to Peggy.
Thank you, Bill. I wanted to start off by commending the governor, of course, and the task force and the staff for taking on this, what probably feels like a behemoth adventure, looking at prescription drug prices and how to make sure the citizens of Wisconsin are taken care of. To echo a little bit of what Bill said is I'm focusing on the 340B program. And it might seem odd that we're focusing on the 340B program when it looks like you have kind of bigger fish to fry here. But my main message to you, if you doze off because it's late in the afternoon, you hear nothing else that I may say today, it's that the 340B program is a drug discount program that is working and has been working for 30 years. And so in anything that the state of Wisconsin does, we'd like to leave the message with you today. Please be very careful not to upset the 340B program, in particular because of its incredibly helpful, the success it's had really with Ryan White clinics in particular. So do I move these slides or do you all? Let's try. There seems a time delay. There we go. So who am I? I'm Peggy Ty. I'm a principal at Powers Law, and I have nearly 30 years of government relations experience here in Washington, D.C. My practice focuses on patients, providers, and hospitals, and I am also very focused on the 340B program. I'm speaking to you today on behalf of the Ryan White Clinics for 340B Access, otherwise known as RWC 340B. And that organization, of which Vivint is a part, and one of our members of that organization, we're a national organization of HIV/AIDS medical providers who care about the 340B program because they're participants in the 340B program. My work focuses mainly on legislative work and advocacy, and I recently testified before the Tennessee Senate on discriminatory reimbursement. So dismissing with that, boy, I have a delay here. Let's try again. Nope. Can somebody else advance that one for me? For some reason, I'm not doing it. There we are. Thank you. So who are safety net providers? Bill did a great job of talking about how Ryan White clinics and FQHCs are 340B covered entities and how there's eligibility rules and applications and auditing and all these other methods to make sure that you are eligible and in compliance with the 340B program. But I thought it would be helpful to mention two things. One, that this again is at no cost to federal state taxpayers to administer the 340B program, to give the discounts from the manufacturers to the safety net. And these are the types of other groups who are 340B safety net providers that are defined in federal statute. And they're all not-for-profit groups, by the way, the Ryan White clinics, community health centers, children's and cancer hospitals, hospitals that care for more Medicaid or Medicare patients, otherwise known as DSH hospitals, state AIDS drug assistance programs or ADAPS, hemophilia treatment centers, and other safety net providers. So moving on, I clicked the mouse. I'm really paying attention, I promise. And it's not moving. Next slide, please. Okay, so I would like to talk to you today about discriminatory reimbursement. This is a term that refers to the growing practice among PBMs, and I know you've had some discussion about PBMs today, and other third-party payers, and recently manufacturers who are offering 340B safety net providers different rates because of their status as 340B entities. Some of these groups are establishing 340B specific barriers to participating in the payer's pharmacy network. Others are excluding 340B safety net providers from the pharmacy networks entirely. And some are determining, and this is recently coming from some manufacturers, determining which drugs it will offer as a 340B drug. There were threatened lawsuits about that, which I'll talk about in a minute. There is another pharmaceutical manufacturer and some other allies, we understand, in the last 2 weeks that is creating a voluntary reporting scheme that would undermine the safety net, we believe, at this point. So moving on, next slide. That's your quick overview on discriminatory reimbursement. So what has the federal government said about discriminatory reimbursement? Well, in the last couple of years, the Health Resources and Services Administration, which Bill told you is the overseeing body through HHS that oversees the 340B program, has said that if covered entities were not able to access the resources freed up by the drug discounts, there'd be no incentive to become a covered entity. There'd be no incentive to participate in the 340B program. HRSA has also said a couple of years ago, by pursuing a discriminatory reimbursement policy, insurers may make it cost prohibitive for certain providers to participate in the program. So HRSA is on record without question saying that these kind of actions are not in the spirit of the law and would be harmful to the 340B program and would erase all of those good things that Bill was talking about. They've been given the ability to provide because of the 340B program. I'm gonna try to, nope, still not working. There we go. The response from the safety net. So what is the safety net? And again, I've described those groups to you, Ryan White Clinics and others, is that the safety nets are united in the belief that discriminatory reimbursement undermines the purpose of the program, because in some instances, it effectively transfers the entire financial benefit of the program to non-340B PBMs or to payers. And those two groups are by definition for-profit and not-for-profit. So we think that is a complete undermining of the 340B program when you're taking money from the safety net and giving it to for-profit entities. Safety net providers also believe very strongly that reducing the safety net providers' resources for care would probably translate into an increased cost to taxpayers. So again, all the good work that Bill and hundreds of Ryan White clinics and other covered entities around the country are doing that no insurer pays for, they wouldn't be able to do that anymore, because the genius of the 340B program is that it enables those safety net providers, those communities, to determine how to use the savings from the program to help their communities as their communities need it. So Ryan White Clinic in Wisconsin is going to be, could be wildly different in a rural part of the state as opposed to an urban part of the state. 340B takes that into consideration, recognizing that the resources provided through the discounts can be used differently depending on the community. I would also mention, and Bill mentioned this as well, but I think it's very important that many Ryan White clinics are on the front lines of the pandemic. They're also fighting in the midst of the HIV/AIDS epidemic and are getting really close and doing a fantastic job. Anything to diminish their ability to fight either the pandemic or the epidemic is something that covered entities, Ryan White clinics in particular, will view with serious skepticism. Some examples of discriminatory reimbursement that we've seen from PBMs and insurers, and I'll talk about others in a minute, are that in some PBM manuals and policy statements, there is specific language in their documents, their policy statements and manuals that say 340B entities are going to be treated differently than non-340B entities. I think that's by definition discriminatory. We've also seen dozens of proposed contracts for pharmacy services, noting that 340B entities will be paid a different contract term that happens to be exactly less the 340B discount from the previous year. So that is also pretty obvious that that is discriminatory based on the entity's status as a 340B entity. We've also seen flat out contract terminations specific to 340B entities that are not noting any cause, which is troublesome, and also exclusions from provider networks that I've talked about before, or forcing all 340B entities into 340B only networks. Other examples of discriminatory actions we've seen recently from manufacturers, Merck, I talked about briefly at the beginning of my presentation, is that on July 6th, Merck asked 340B providers to submit information for all its products purchased under 340B to a web-based platform. We are still analyzing what it is that Merck is attempting to do. And we are in discussions, going to talk to them and find out more about what it is they're going to do. But we have some alarm bells going off right now because in those documents coming from Merck, Merck said that the failure to submit data from covered entities would require them to take a less collaborative and substantially more burdensome approach. So there was a threat in their materials that if you don't sign up for our program, we're going to be less collaborative and we're going to be more burdensome in what we're asking for you next. That, of course, didn't go over well with covered entities. Safety net providers expect that this penalty for not signing up for this system may very well be that manufacturers will refuse to pay wholesalers the difference in the price wholesalers paid in the 340B price. What does that mean? That means if you remove wholesalers from the 340B sales, they won't participate because they're not going to participate at a loss. Therefore, you're effectively removing the benefit of the 340B program from the safety net by cutting out the wholesalers. So those two things, again, are troublesome at first blush. We're having further conversations. We want to take Merck at its face and have discussions about what it is they're proposing to do. But those two issues trouble us a bit from the get-go. Another example of discriminatory actions, again, recently within 24 hours of that July 6th action by Merck, Lilly made an announcement, Eli Lilly, that it would no longer provide a particular drug, Cialis, to contract pharmacies. And I could spend 3 hours talking about contract pharmacies and bore you all to tears, but generally contract pharmacies is one of the means by which covered entities are able to facilitate moving drugs within the 340B program. This is a very dangerous precedent to allow manufacturers to simply by their own fiat say, I'm going to pick a drug and I'm going to decide to remove this from any 340B contract pharmacy. And so there are folks who are very angry about this and frustrated and talking about how this would be absolutely objectionable to the 340B program because allowing manufacturers to pick and choose drugs they want to provide to a federal program that they're required to participate in seems really counterintuitive. This announcement was also posted on HRSA's website. We think this is a real challenge to HRSA's regulatory authority. There's no statutory obligation to provide 340B priced products to contract pharmacies is what Lilly is arguing. So it's a question about whether or not HRSA, the federal agency, has the authority or not. And what Lilly is suggesting is HRSA says they don't have the authority, so we're going to go do our own thing, which has caused a giant uproar among covered entities. It is the week where 340B coalition is meeting, and there are very serious discussions about action, including lawsuits, as I mentioned. Here is what words actually from Lilly about Cialis and what they're going to do and how they're going to do it through contract pharmacies. I thought it was important to take their words and not just talk about what it is they're doing. This is what they've said, and this is what is troublesome to covered entities, or the safety net, as I also call them. There are several states who have recently, just in the last couple of years, enacted state prohibitions against discriminatory reimbursement. This is because it's happening. All those examples that I gave you are troublesome, and state legislatures have taken notice of them. So laws have been enacted in West Virginia, Minnesota, Montana, Oregon, Rhode Island, South Dakota, and Utah. And recently, Georgia passed a pro-340B prohibition on discriminatory reimbursement. That legislation is waiting for the governor's signature in about a week or two. Legislation was active in Tennessee and Florida, interrupted by COVID, and is not moving this year, is my understanding. But Tennessee did advance a template resolution to be in support of the 340B program, I think is important. I'd also say that pharmacy benefit manager reform is hopping on the state level. It was very active last year and is still, even in COVID times, very active in the state legislatures this year with dozens of states. I think it was 37 by my last count, and it might have been 40 last year who were doing some kind of PBM reform. This is the vehicle where we're seeing discriminatory reimbursement prohibitions happen. So I thought that was important to point out. Here is our chart. if it's useful to anybody about those laws and what happened with them and the passage of them and what's included. West Virginia at this point is probably the strongest of the laws and in our opinion, and what we support as a really good model going forward. Georgia also is a very strong law. Here is the Georgia law. I put it down here for anybody's reference if you want to see it, but basically the prohibition is that PBMs can't discriminate in reimbursement, assessing fees, excluding pharmacies from the network based on their participation in the 340B program. So it's fairly simple what we're asking for, and some states are agreeing with us and recognizing there's a problem and taking action. I would encourage Wisconsin to take a very close look at this and see if Wisconsin can be one of those other states who have taken a stand against discriminatory reimbursement. The Tennessee resolution is also simply talking about the 340B program. It's worth noting, I think, at this point that 340B is regulated at the federal level. So state legislators, frankly, can't spell it. 340B is not something they've had to deal with. It's not something they've had to know anything about because it's been regulated at the federal level. So there's a lot of education from all stakeholders in the 340B space to talk to state legislators about what 340B is. You shouldn't feel like, when you're talking to a legislator and they don't know what it is, that's a surprise. It shouldn't be a surprise. It wasn't in their court until now. It has become in their court because of our prohibitions against discriminatory reimbursement. It's come into our court because of some of the issues around regulation of PBM and pharmacies. And when you think about pharmacies, there are pharmacies that are run out of covered entities, out of the safety net. So the fact that we have our own pharmacies and you're trying to regulate PBMs, sometimes you could accidentally harm the 340B program. So that's another cautionary tale. If you're looking at PBM reform, please make sure there's not an unintended consequence on 340B entities. The feds made that mistake and covered entities' hair caught on fire, and we went and resolved that problem. So just pointing that out if you're moving towards PBM reform. So why are these prohibitions on discriminatory reimbursement necessary? Just a couple points I'd make here is that, as I mentioned, manufacturers are required for exchange for their participation in Medicaid to provide these discounts through the 340B program. The history of this, I think, is kind of cool. Senators Hatch and Kennedy got together when drug prices started to go through the roof about 30 years ago and said, what do we do? And Senator Kennedy said, you know what, let's put caps. Let's put caps on all the drug prices. And Senator Hatch, who was a raging Republican conservative, said, oh, no, not, no, over my dead body, we're not putting caps on drug prices. So what we should do is, well, who are we trying to help here? We're trying to help those most in need. So they made up a program and made up a policy which gives drug discounts to the safety net. It is really pretty genius that discounts would flow directly from the manufacturers to these entities as prescribed by law. The problem has become that manufacturers are finding ways to avoid what we consider their responsibility to provide these discounts to safety net providers. I think then, Bill mentioned this as well, that they were unsuccessful in trying to shrink the 340B program in Congress. Why on earth should they be permitted to do it through those with whom they contract, the PBMs and insurers, or through state legislative action or by their own action directly? If Congress won't change the law to accommodate their frustration with the 340B program, why on earth would the rest of us let them just change the 340B program, which is a federal program? I think it's also very important to note that 340B discounts represent just over 2% of the overall drug company revenues. Now, this is the American Hospital Association and the 340B Health have been saying this for years and doing the analysis. There is some squabble about which numbers you look at. The other side will tell you that they look at wholesale acquisition cost. Wholesale acquisition cost is like the list price on a car. It is not all that relevant or useful of a statistic if you're citing something that nobody pays. So if you hear the other side, manufacturers in particular, some manufacturers, not all of them, But if you hear them say, oh, no, 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 the number's 4 or 5%, it's not 2%. Those goes 340B, safety net people are lying, it's really 4 or 5%. We're looking at a different methodology. We're weighting these numbers very differently. And frankly, if it's 5% of total drug company revenues to give a benefit to the safety net, I don't think there should be a grand objection. If it was 50%, we'd have a different conversation. But if we're quibbling between 2 and 5%, I think this is the responsibility of the manufacturers. It does such good in the community, like what it's doing at Vivint and other Ryan White clinics, that this is a good trade-off and a great compromise that was created 30 years ago. Also, 340B is one of the most effective means of providing discounts to most in need, as I've talked about before, at no cost to federal state taxpayers. If you don't, the alternative is if you take this away or harm this program, you're gonna have to tax people more. You're gonna have to find the money somewhere to go pay for those services if you want the same results that are viral suppression and people are being cared for and they're not going into emergency room settings for primary care. All of those things you would lose or are threatened if you threaten the 340B program. So not protecting the program, in my mind, represents the opposite of tackling rising drug prices. So the first message is do no harm. The second message is protect it. Please protect the 340B program, because if you don't, you're doing the opposite of tackling rising drug prices, which I know is this task force's main goal. So now more than ever, the safety net is doing what it was always meant to do, and it's protecting public health. And Ryan White clinics are not going to be able to do this if there's any harm to the 340B program. We have a lot of research, statistics, information, talking points on our website, but the one on this particular issue, RWC 340B talking points on discriminatory reimbursement, are on our association's website if you want to take a closer look at that. And the main ask, which I probably peppered throughout this speech, is please protect the safety net from discriminatory reimbursement. We're asking Wisconsin and all other states to protect us by prohibiting manufacturers or their agents from shrinking the 340B program. Thank you for the opportunity to present.
Great, thank you both. Really appreciate the information. We have been talking about 340B throughout our meeting, so it was nice to hear a little bit more detail and specifically around the issue of discriminatory reimbursement. I know that's something that Tony has brought up in previous discussions, so thank you for that information. So question, I guess I will say first before I open up for questions, Peggy, to your point about PBM reform, Wisconsin was one of the states that was looking to probably pass some PBM reform legislation earlier this session, and then COVID hit and the end of session was canceled. So there's some talk that maybe that might still be taken care of sometime this year through an extraordinary session, but if that doesn't occur, then we'll have to start over again when the legislature convenes in January. So Alan, I know you have a question. I'll start with you.
Yeah, sure. Thank you for that presentation. It's good to get various perspectives and have a good discussion, and we'll most likely continue that. You had mentioned that some plans or PBMs are not including certain dish hospitals or provider systems in their network, and I'm guessing that it's probably because when you look at any PBM contract, PBMs are explicit in saying any 340B claims are not rebate eligible, so that becomes a problem for the plan. Those savings then basically are affected. So I would think that that's part of it. I also know that you had mentioned 2% of the list price, and you make a good point. Is it WAC or AWP? But I think of AWP, 7% is affected by 340B. A couple years ago, it was only 5%, because we know the program is growing at a very rapid rate. And I do fully support the concept and application of 340B, where it's a rural facility or a facility in need because of disproportionate share of low income, and using those funds to help people specifically and directly. but also certain perhaps public health or population health programs, fully supportive. The problem is that it's also abused. We've got a lot of perhaps not the best players, and that's very clear. And there's many studies that support that. And I did send those references to Nathan and ask that that be shared with the group. You read it, please, everyone, and you make your own decision. We have issues, for example, where we have a provider system in this state that's aligned with a large chain and has hundreds of 340B contract pharmacy agreements. And I know from an analysis that a lot of our claims and a lot of money goes through there, even though they're not low-income people or indigent people. In fact, my prescription potentially could be processed as 340B. None of the savings goes back to the plan or a person on a high deductible health plan. It goes back to the facility and basically affects the net income for a not-for-profit organization. I know that there's 2 teaching hospitals outside of this state where 50 to 60% of their net income is driven by 340B. We know there's a lot that has incented facilities to do private practice specialist acquisition, because then they can use the income from specialty infusions, and that generates a significant amount of profit. So I think, I support 340B in principle and its proper application. No one can negate the benefits to it, or like the AIDS Resource Center. But when it's used to drive profits and it changes behaviors to the negative, I can't support it. And I would think, if anything, we should consider somehow that it's made more transparent. And if 340B is used, every provider system checks eligibility. And if somebody's got an $8,000 high deductible and a family of 5 and only making $25,000 a year, I would think that would be a good place to use 340B. There are a lot of people that are financially distressed in Wisconsin. And I find it remarkable that from a U.S. News and World Report survey 2 years ago, out of the top 10 most expensive provider systems in this country, 4 were in Wisconsin. And I don't think of Wisconsin as like the financial mecca of the United States. We basically have a much lower median income, and many of our rural communities need better support and don't need to be subject to high healthcare costs. Thank you.
You covered a lot of ground, Alan, and I have a feeling you and I could talk for 2 hours about this, but a couple of points I think are important is the grantees in the program in particular, for whom I'm speaking today and Bill is speaking, are fully transparent in the 340B program. They are required to report a plethora of things as far as what they do and how they use the 340B program. I think it's really knee-jerk to be able to say, well, if we just gave the benefit only to low-income people, then it would all work out better. But I think that really misses the structure and the concept of the 340B program. Is you're not giving to an individual patient. If you gave to an individual patient, manufacturers could do that right now. Kind of like the last presenter said, let's lower the cost of insulin. That would be a different formulation, an entirely different way of doing things. And what it would take away from the 340B system is those additional resources.
Well, what's interesting is that was the original intent of the program because of the Medicaid Best Price Rebate Act in 1990. It was squeezing the balloon, and manufacturers, of course, couldn't, which made sense to me, couldn't comply with low costs to hospital systems to help with the indigent care. So the whole point of it was to basically help subsidize unpaid care and help people with medication costs. It's really turned into quite the monster of a business model. I would not support, and I would fight and lobby aggressively against any sort of discriminatory reimbursement plan. I think there needs to be some very lengthy conversation. We need to understand it more. Support it where it's appropriate, but we know that it's misused, and that's not solving any of our drug cost or healthcare problems. I appreciate your perspective, though. Thank you.
Thanks, Alan. Yeah, we do have 2 more questions we want to get through, and then just a few comments to make before we wrap up here at 2 o'clock. So, Peter, you said you have a comment?
Yeah, Peggy, Bill, this is Peter Photos from Pharma. I can't make any comments on what's going on with Merck and Eli Lilly. Obviously, those are business decisions with whatever they're doing. And I'm sure you guys get that.
Right.
I just wanted to make the comment that as far as the 340B program goes in pharma, our industry, we are wholly supportive of the program. We've just had a lot of what Alan's already articulated, but a lot of concerns about the growth in the program, especially since the ACA, which expanded Medicaid. A lot of hospitals have consolidated and acquired.
Oops.
Peter, I think we lost you. Your screen froze and now we lost audio as well.
Reimbursement and used it to,
Now you're back.
not necessarily for the underinsured and uninsured, but maybe for other things. So what we've always looked for is more of an insight into how that money's being used. Like I said, what individual companies are doing, I can't comment on, but as far as industry goes, we do support the program. We just think there needs to be a little bit more oversight at HRSA.
Well, if I could just respond to that for a second, and I appreciate, Peter, that perspective, and honestly, I can say this, we've long partnered with pharma in a lot of different ways. The drugs manufactured to help people living with HIV live longer are nothing short of remarkable if you look at the history of pharmaceutical research in this country. There's no doubt about that. And I've also been lockstep with meetings from folks in Gilead and some of the other large manufacturers in our space who have said Ryan White clinics are using this program exactly as it's intended. One of the things that I think it's really important to take into consideration as it relates to the 340B program is that, again, this is not a drug pricing program that helps pass through those savings directly to a patient. It's set up to make sure that covered entities, providers, are the ones participating in the program. And to our end, because our eligibility to participate in this program is driven by regulations based in federal law under the Ryan White program, we're specifically limited in terms of what we can take those savings and reinvest them in. For example, if we have an individual come to one of our clinics and that individual is HIV negative, but would be a great candidate to get on pre-exposure prophylaxis, which is a drug that's used to both treat HIV, but is also effective in preventing individuals at risk for HIV from acquiring it, we cannot use any 340B savings generated from our participation in the Ryan White program to extend any services, including access to care or medications, to an HIV negative individual, because it's a violation of the statute that underpins our eligibility to participate in the program. So I want to make sure that there isn't an impression that the 340B program is the Wild West of healthcare financing. And I don't want to discredit people's concerns and want to look into it, and we support transparency. But I wouldn't be doing my job if I didn't say there are some pretty strict guardrails in place for how clinics like ours can participate and utilize this program to extend access to the healthcare safety net for tens of thousands, if not millions, of vulnerable patients across the country.
I think, Bill, it's important too, just on that last point, is that the state of Wisconsin, I don't think is proposing to upend the 340B program. I don't think you're talking about the kind of reforms that Pharma was talking about when they were trying to fight this in Congress last year. I think what we're saying is, when you do what you think you need to do on prescription drugs for the state of Wisconsin, please consider that there are other practices that are going on outside of the 340B safety net, where other groups are trying to undermine the 340B program. We're asking you not to do that. If we want to change the 340B program, let's do it in Congress. Wisconsin's probably not the right place to do that. So protect us from the bad behavior that we're seeing is all we're asking for.
Yeah, and Bill, I would in no way try and diminish the work that you and your clinics do. As an industry, a lot of our issues, they've been brought up in multiple studies. Milliman had a study about the hospital's acquisition cost for physician-administered medicines purchased with a 340B discount, and what they've actually done with that. There's been a disconnect, and that's all I was bringing up. It was in no way to impugn what you and your clinics are doing, which is obviously really great work.
No, Peter, I really appreciate it, and I understand that. And that's a conversation we regularly have. And the only thing I would say to that, I'm not here to defend the hospital association or the hospital systems or anything like that. I would only just say that when our patients need access to specialty care that we're unable to provide, whether it's oncology, radiation, other kind of specialty services like that. It's very often those dish hospitals that are our partners in rounding out the safety net for those patients to make sure that they've got access to care. But please don't misconstrue. I totally understand the need to be transparent in this program and make sure that everyone is playing by a well-established set of rules and using the program as intended.
Great. Well, thank you everyone again. Bill, Peggy, thanks for the presentation and for answering some questions. We're down to just a couple minutes here. I do want to take a little bit of time and kind of talk about our next steps and what we're going to be looking at as we look ahead to the August meeting. So today was our final day of presentations. We will be meeting again on August 25th. That meeting will be entirely dedicated to discussing the policy options for potential recommendation by the task force. We will then prepare a final report that will be provided to the governor probably sometime in September is what we're looking at. Prior to the August meeting, we will be sending some additional information to all task force members about how that meeting will be structured and which policy options we'll focus on. I do encourage everyone to send any thoughts or any suggestions prior to the August meeting. We really want to make sure that everyone has a chance to have input into this process, have their voices heard in terms of any policy options that you would like us to focus on. I would also encourage any members of the public or interested parties to send any suggested recommendations or feedback that you have. We have been getting some feedback already from some groups, so we really appreciate that. We will send out an email to the interested parties email distribution list just as a reminder to do that. As Alan mentioned, we'll send the information that he had sent to us regarding the 340B program. If anyone has any other information you'd like us to share with the task force members or interested parties, please send that to us and we can get that distributed. Just really appreciate everyone's involvement today and through this whole process. And I guess I'll pause there and ask if there are any questions before we adjourn for the day. Okay. Well, hearing none, thank you again to all of our presenters. Thank you for the task force members for a lot of good questions and your engagement today. And like I said, look for an email from us in the coming weeks, and we'll see everyone again on August 25th. So thank you.
Thank you.
Thank you.